Good afternoon, everyone. You are very welcome to the HSE Overweight and Obesity Let's Talk webinar. The panel will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you're using an iPad, you will find this feature located at the top of your screen. Without further ado, I will now hand you over to the Assistant Professor at Trinity College Dublin, Dr. Brendan O'Shea. Thank you.
And a huge welcome to all participants who are signing on for this afternoon's webinar. My name is Dr. Brendan O'Shea. I'm a general practitioner with an interest in overweight. I'm the outgoing chair of the Clinical Advisory Group on the Obesity Programme. And on behalf of all of us who've been involved in devising this afternoon's programme, we really hope that you're going to take a lot out of it, that you'll find it energizing, that it's an opportunity to discuss some of your own concerns, your insights, around overweight and obesity, and greatly looking forward to everything that's going to follow. I'd just like to briefly introduce the program, and then I shall stand back. And my role for the rest of the first half of the session is mainly timekeeping. We have no doubt that the discussions will be bursting at the seams, but as a respect to yourself and getting all the fantastic program covered, we'll be very clear and reasonably blunt about timekeeping. So it's overweight and obesity, let's talk. And in particular, we understand there are very different many ways of looking at healthcare. Surgeons like to look at numbers of procedures and the technical aspects of what they do. I'm a general practitioner. General practitioners, and I think for a lot of people, like to focus on the discussions that we have. In today's program, the discussion is very much to the fore. We understand that overweight and obesity is a concern for a lot of people. We understand that it's reflected in millions of consultations each year in the Irish health system. We know that some of these consultations really haven't worked out or haven't been effective, but we really hope that we're taking steps to improve that, both in our work today and in the work of the Clinical Advisory Group and the Obesity Management Programme at the HSE, and in all of the conversations that we have in our schools, in our clinics, in our conversations over coffee, in our conversations in families, that we can enter these conversations in a way that makes them more respectful, more useful, more likely to act as a support and a resource to provide the right kind of guidance to lead us to better outcomes in what is a challenging and difficult condition, which is overweight and obesity. In terms of the program, we are running a poll at the beginning of the program, and if we'd like to pop a poll up just now for you all to consider, and we'll be running a similar poll at the end of the program to see if we've changed hearts and minds in the course of the day. So don't overthink it, but just consider, do you believe obesity is a disease? Yes or no? Do you feel it difficult to discuss overweight and obesity? Yes or no? Don't overthink, just mark. And again, we're very keen. We're thrilled at the moment. There are over 400 people and the numbers are increasing. We really would like to know what your response to those polls are. Shortly, I'm going to hand over to Minister of State, Frank Feehan, who's the Minister for Public Health, Wellbeing and the National Drug Strategy. And he's providing opening comments, recognising the importance of this topic. And after that, we'll be moving rapidly on to Professor Donal O'Shea, who's the clinical lead of the obesity programme. He needs no introduction. He has a long-standing track record on both research and clinical care, working out of St. Vincent's in Loughlinstown. And Donal will be bringing you into the programme, what's happening, and we'll be talking to you about our model of care. After that, we're moving very rapidly on to discussions, to the let's talking part of it. So without any further ado, if I can just hand over to Minister Frank Feehan and make sure you vote in the poll. Also make sure that you consider the hashtag. We have a hashtag for today. It's overweight and obesity, capital O, otherwise small letters, overweight and obesity. So just generate some Twitter activity.
Good afternoon, everyone. I am delighted to be opening this webinar as Minister for Public Health, Wellbeing and the National Drug Strategy. I want to welcome all of you who are participating online, and I want to thank the organisers for giving me the opportunity to say a few words to you. It is great to see a collaborative event such as this, which gives both patients and those working in healthcare settings the opportunity to hear different perspectives and thoughts in relation to overweight and obesity. And I'm pleased to see that this event is going from strength to strength after 3 years. Obesity certainly is a complex area, which needs action on a number of fronts and a coordinated approach from government. This is recognised in the Obesity Policy and Action Plan, which has been in place since 2016. The Healthy Ireland Strategic Action Plan 2021 to 2025 sets out a number of focus areas and actions for Healthy Ireland for the coming years, including in relation to overweight and obesity. Key obesity initiatives include delivery of community-based weight management programs in chronic disease hubs and the Sláinte Care Healthy Communities programme to support implementation at a local level in line with the increased focus on reducing health inequalities. A hugely important development this year was the launch of the HSE model of care for the management of overweight and obesity. We now have a model of care which sets out how the healthcare for children, young people and adults living with overweight and obesity in Ireland should be organised and resourced now and in the future. It will ensure that the right care is delivered by individuals with overweight and obesity at the right time and in the right place. And I congratulate Donal O'Shea and his colleagues for all their work in putting this model of care together and through the Obesity Policy Implementation Oversight Group and subgroups the department will work to achieve its implementation. I am delighted to see the progress being made on the training and resources being made available to healthcare staff, including the Talking About Weight, a guide to healthy lifestyle behaviours book, and the new Making Every Contact Count obesity training module, which will make training for brief interventions in overweight and obesity available for staff by the end of the year. I am particularly pleased to see the involvement of the Irish Coalition of People Living with Obesity with this event. It is so important that the voices of those living with obesity are listened to, and I am glad to see that this is increasingly the case. Finally, for those of you joining today as interested parties, patient representatives, or living with overweight and obesity, I hope that this event demonstrates the commitment your health service has in working with you and providing a broad range of appropriate treatments at the right time and in the right place. I firmly believe that we are now in a good place to make progress in the years ahead. Thank you.
Thank you very much, Minister. So this afternoon's programme is important for several reasons. One of them is that it gives us an opportunity on the programme to highlight some of the events around obesity care. Obesity care has been difficult in the past, but many of us believe that things are moving on, that there have been really significant changes, even despite the pandemic. One such individual is Professor Donal O'Shea, who is the obesity lead for the HSE obesity programme, and really plays a key role in communicating around the programme and up unto and including the launch of the new model of care for obesity. Donal, take it away.
Thank you very much, Brendan. And the results of the poll, I was just looking at before I start my talk, and it says 82% of the people who are online today consider obesity to be a disease, and 80% consider it a difficult issue to raise. And we really couldn't have a better starting point in a lot of ways for this afternoon, and even the choice of title about, let's talk, because the first step in managing any condition is raising the issue. And I'd like to thank the Minister for opening today. I think it reflects where we've come in terms of obesity as a disease and as an important issue that the Minister would open and be fully up to speed with the activity that's going on in this space at the moment. It's very, very encouraging. And if seeing more than 500 people linked in with to a webinar on the subject doesn't tell you how much things have changed over the last 30 years, then nothing does. I mean, 20 years ago, if I was asked to a school to give a talk on healthy eating and obesity, you know, there was times when I was down there talking to the principal and the parent who thought it was a good idea. Now we have an event like this with a minister opening it. So it's, you know, we need to build on where we are at the moment. If I said things have changed a lot in the last 30 years, for me, I have a cousin who's a home economics teacher in Australia, and she gave me this slide of Bondi Beach, and she uses it teaching in her classes just to show how much things have changed over the last 30 years. So if you went to Bondi Beach now, you would see everybody wearing hats, t-shirts or sunscreen. You would see a lot more people living with obesity, and you would see a lot more people with their heads down in phones. You know, the eye contact here is eye to eye, people chatting, not iPhones. And the analogy with melanoma is one that I'm using increasingly frequently. You know, malignant melanoma is a condition that you develop because you have a genetic predisposition and your skin gets too much sun for your genes. And the treatment is not put on a hat and wear sunscreen. Obesity is a condition that is developed because you have a genetic predisposition and the environment provides too much energy for those genes. And yet there is still a narrative out there that the treatment is, well, just eat less and move more. So what drives the development of a condition is not what is the treatment for the condition. So to tell somebody with malignant melanoma that they should put on sunscreen and wear a hat as their treatment would be considered negligent and offensive. To tell somebody living with obesity that eat less, move more is their treatment is negligent and offensive when you understand the biology and the drivers. And that is not to say that prevention measures are not an important part of treatment. Absolutely they are. But the treatment is different, and that's understood now, and therefore we need to change. We do understand now, and this is just a very brief video of the dynamic of fat. And within fat tissue, of which I'm a big fan, because it's a magical store of energy and a magical releaser of energy when you need energy released. But there is a dynamic going on within adipose tissue that is protecting your weight. And when you lose weight, it is a threat to your existence. So it is, you know, important that you understand that when you lose weight, your body will try and bring you back up to your previous best weight, which really from a survival point of view is the biggest weight you have ever been. So I'm going to talk briefly about the model of care. As the Minister mentioned, I'm going to describe the levels that are there for adults and children. I'll talk about what's currently available and being developed, and there's a lot being developed and becoming available at the moment. And I'm going to say just a couple of words about the impact of COVID-19 on obesity and really on the energy within the health service to fund treatment for obesity. But before I do that, I would like to introduce you to Emily. And Emily is a 44-year-old lady. She's living with obesity. She's living in rural Tipperary. She has 3 children. She works. She is 18 stone and has complications from her obesity. And over the years, to come as no surprise, she has had many treatments and many efforts at weight loss. And we're going to be kind of coming back to Emily throughout the afternoon at various time points, and just thinking about what we're discussing in the context of Emily and her family and her environment. And when it comes to the model of care, which is a high-level document, it's a strategic document, we do need to think, how does it apply to the individual? How will it apply to their family members? So there's a strategic role to the model of care, which spans 5 different documents over the years. Ultimately, I think the Obesity Policy and Action Plan, which Minister Feehan mentioned, and the Sláinte Care Implementation Strategy are the 2 most recent and the 2 most crucial. A model of care is a one-off document. It's high level, it's not prescriptive. I did an interview with Ray Darcy during the week and on the radio, and when I walked into the studio, he held up the model of care and he said, well, this isn't very good, is it? It's really been written by a committee. And I said, well, actually, it has been written by a committee, and a very invested committee. And I think it's very good. Is it boring? I mean, it's a high-level strategic document. Well, of course it's boring. But if you, I suppose, implement it and live it and make sure it is lived, then it becomes, for me working in the field of obesity and for people who are living with obesity, the most important document of my career. I think the context is really important, and there's never been a better time. So the model of care is a key deliverable from a Department of Health point of view. And it was approved in the HSE last December and launched 3 months later. And that's a record for approval to launch for any model of care. It's usually at least 1.5 years from approval to launch. And I'll briefly come back to that later on. The HSE corporate plan has made it a key objective within the whole chronic disease area. A couple of months ago, the Department of Finance, for the first time, said we need to acknowledge the challenge and the challenge of prevention and treatment of obesity. I think that may be almost the first time the Department of Finance have used the word obesity in a document, and I think it's an important moment. And then the final piece that has energized the last number of years is the patient voice. So it is the Irish Coalition of Patients Living with Obesity, who represent individuals like Emily, and who increasingly are being joined by people that is adding to the imperative to deal with this. Briefly, to look at what does the chronic disease model of care look like? Well, for obesity, our chronic disease model of care aligns with the Sláinte Care vision. And Sláinte Care want to deliver care in the community close to the patient and the individuals living with the conditions. They want this care to happen within the primary care and community settings as much as possible. And level 0 is about having a condition but being able to live well with it. Level 1 is within general practice, where the primary care team are looking out for the condition, detecting it, and raising the issue in an appropriate and sensitive way. And then level 2 is what's available within the community specialist ambulatory care hubs. And these are a vision for Sláinte Care to provide chronic disease management within walk-in centres within the community. Some will be the primary care centres that already exist, but new facilities are going to be required. And then you've got your acute specialist hubs where you're dealing with more complicated end of the condition, but still within the community setting. And that's level 3. And level 4 then is, you know, what goes on in the hospital setting. And if we just look at this briefly, for the children's model is along the same lines, but it's a little bit different. It only goes up to a level 3 for a few reasons that I just don't have time to go into at the minute. But level 0 is still what's available in the community. So it's self-management supports, enhanced parenting programs like Healthy Food Made Easy. General practice is still all about what's available, you know, detecting and raising the issue. And you know, the new GP contract has regular weighing of children as part of the program. And then you have to have within the community, if you identify a problem, something that you can refer onto that will help intervene. And that's in children, that's the community specialist obesity multidisciplinary team. And there's 2 areas that have been identified for the developing and the piloting of a community specialist MDT for the management of childhood overweight and obesity. And then level 2 is what's going to go on within your regional hospital setting for children with obesity who either haven't made progress with the community specialist intervention, or when they're identified already have complications that need hospital intervention. And then level 3 for children is the space where children are going to need aggressive intervention, or adolescents are going to need aggressive intervention for their obesity, up to and including bariatric surgery. And for that, you need a full multidisciplinary team within the hospital setting. So within children's services, so what's available, you've got the things like the START campaign to promote awareness, the parenting programs, the Healthy Food Made Easy within level 0. The GPs are checking and the public health nurses are doing health and wellbeing checks. What we haven't had up until now is anything at level 1B, 2 or 3. And level 1B is being developed in 2 of the community health organization areas. Level 2, what's going to be available regionally really is going to be determined by what happens within level 1B and that whole project. But what we definitely need is that level 3 tertiary care for those with severe and complex obesity in childhood and adolescence. The adult model of care, again, if I'll just move on to the next slide, because this tells you what's available. So level 0, we're looking at the Making Every Contact Count program. We're looking at signposting to community supports, and then self-management and education supports that will be available to all. Level 1 within general practice, you're looking at the chronic disease management contract, where individuals are going to have, among other risk factors, their weight and heights recorded. And now you will be able to signpost to an intervention within level 2, which is a community-based adult weight management program that's currently been developed with dietitians being recruited to deliver that. And that process is being tested this year, piloted and next year, and then rolled out nationally next year. Within level 3, there are plans to recruit 6 full multidisciplinary teams to be based in the 6 regional health areas to begin delivering care for patients with severe and complex obesity who are identified through the level 1 and 2. And then in level 4, that is effectively the kind of bariatric surgical approach for patients with severe and complex obesity who we know will benefit from bariatric surgery. And there are plans within the model of care to have, in the first phase, 3 surgical centres performing and building up to performing 400 surgeries each, so that over the next 3 or 4 years, we build up to 1,200 surgeries a year for people living with severe and complex obesity. So we've identified the gaps in the service, as I've mentioned, and that is what we have prioritised within the estimates process for 2022. So the model of care is now agreed and launched. Every level of the model has to be working for the model to flow. So if GPs don't have somewhere to signpost you to, they're not going to look. If when you're signposted to an intervention, there isn't something above that for those who still need intervention, then there isn't an enthusiasm, there isn't an energy in the every level of the model, and it won't flow. Briefly, what has happened with obesity and COVID-19 is that people living with obesity who developed COVID-19 unfortunately had a more serious course with their COVID-19. And really what that highlighted to the healthcare providers was obesity as a disease in its own right, not just a bystander, but something that had to be addressed. And the data was compelling. You know, COVID changed our world. On the left, you're looking at medical student teaching 2 years ago, and on the right, you're looking at medical student teaching now. When I stand in front of a group of medical students, the impact of COVID-19 has been huge, and we have learnt lessons. And one of those is that obesity needs to be managed as the disease it is, and also prevented. Because as with most chronic disease, you know, you have to do both. You have to work on the prevention side, and you have to treat.
2 minutes.
So the priority projects at present are the adult weight management program, as I mentioned, and that's being tested at the moment in 2 areas for the pilot to start in January. The childhood obesity treatment MDT, again, 2 areas are going to be rolling that out next year, and the design is ongoing as we speak. The making every contact count, and the most important bit to start dealing with it is the raising the issue, and this module is going to be complete by the end of this year. So there are the things that are happening. The resourcing that's in place is unprecedented. That we've requested is ambitious, but there's huge grounds for optimism. And I want to just finish with Emily, because if we don't apply our thinking to the individual as we're developing our treatment programs and our model of care, then it's not going to be relevant. And what we need is for our treatment programs to be relevant and to make a difference to people living with obesity. Thank you.
Donald, thank you so much for that run through. We're moving now to a brief stretch sitting break or standing break. Do have a look at the Twitter hashtag. It's up on chat, okay? Thank you so much for all the questions coming in. And if I can put it to our panels, if you'd like to take up some of those questions, there are fantastic questions out there, and they're really stimulating the thinking. Donald, I would have to profoundly agree with you. Obesity has been a difficult topic, I think, for all of us. But I think in this country now, and with respect to the international evidence abroad, I think there are grounds for optimism. And I think our health system really is investing. It's really investing. And I think our experience with obesity is improving. And thank you so much for taking us through the model of care. We talk about strategy and models. A strategy, by definition, a strategy is a plan devised by a group of knowledgeable people, which identifies the problems and what's going to be done about those problems. Strategy is an art or a skill. It's the skill where if you've got too many things to do and only so much energy, it's the skill of deciding on the right things to do. A model is a symbolic representation to try and capture a complex system, and this is complex. It's got you in it, it's got many patients, it's got different types of healthcare professionals, it's got administrators, politicians, budget holders, hospitals, GP clinics. But we are really optimistic about the launch of our model of care. The link, there's a link to a web for you to look at, and we really see that this is going to add cohesion as well as the resourcing that's coming on the political side. So enjoy your stretch and stand, keep the questions coming in, do generate some energy on Twitter, and look forward to linking in again in a few moments. Good afternoon, we're back and hopefully you've stretched. We're moving rapidly on and we're really getting to the Let's Talk part of our webinar. I'd like to briefly introduce Susie Burney. Susie is lead at the Irish Coalition for People Living with Obesity. I'd also like to introduce Dr. Mike Crotty, who's a GP. Mike completed his GP training, came top of his class in that year, went to Canada, gained some really interesting experience in Canadian practice in relation to how obesity is better cared for there. And then also Colin Dunleavy, who's a clinical specialist physiotherapist in weight management. And Colin is also part of the team at Loughlinstown. This next part is bringing us into the conversations. And at the outset, I think it's important to understand you may find some of this challenging. We really hope you find it engaging and provocative and useful and encouraging. Without any more ado, can I hand over to Susie and Mike Crotty.
Thanks, Brendan, and we're delighted to be here. So over the next hour, we will have some role play sessions, scenarios between healthcare professionals and people living with obesity. We're going to break this down into 3 sessions, approximately 20 minutes each. And we will first start with myself and Dr. Michael Crotty. We'll be followed by Maura and Dr. Colin Dunleavy. And we also have Bernadette and Dr. Sarah Brown, who will be the last role play. Please do use the Q&A. We would be delighted to read your questions. We see them coming in already, and we'll try and get to as many, but probably with time-wise, we won't get to them all. So we will go straight into it because I don't want to explain too much because we think you need to just see it, and we'll go straight into the first video, and we will come back to myself and Mick to have a discussion afterwards.
Hi Marion, you're back again. What's going on today?
I'm just feeling very tired and very exhausted, and I was just wondering if there's anything you can do to maybe find out why and follow up on what
the last time you were in there, we had a chat about kind of maybe losing some weight, and that might make you feel a bit better. Did you manage it?
I've lost a little, yes. I'm trying to lose a little, yes.
Okay, very good. Because obviously, you know, being motivated and dropping the weight, that's really what's going to do the best thing for your health long term. You know, we can mess around with everything else, but that's kind of the biggest thing. You know, so tell me, you said you're feeling tired.
Yeah, really exhausted and just shattered, and I would assume, having lost a little bit of weight, that my energy levels would have risen, but they don't seem to be doing so. I'm just a little concerned.
Yeah, I suppose, Jesus, sure, with the amount of weight you're carrying around, I wouldn't be surprised you're exhausted. Sure, it's like having a couple of suitcases on your back all the time. Between that and the diabetes, geez, that'd be enough to have anybody exhausted. So it's probably a case, you know, if we drop the weight some more, I think that's probably going to help the most, you know. But you know, as far as kind of dropping the weight, sure, the diet is probably not great, is it? Would there be a lot of kind of takeaways or rubbish or things kind of in the diet? What do you think?
No, not really. And I mean, I've been carrying this weight for 20 years, so why would suddenly the weight be kind of whatever? I mean, I feel I know my body very well, and you seem to think that you know it better than I do. But
well, I suppose I just know that kind of, you know, weight is you know, it's going to kill you. You know, it causes, you know, so many different diseases and problems. You know, and between the weight, sure, if you're carrying the weight, sure, you can't be able to do any exercise either. You know, so I'm sure if you're not exercising, that's going to have you shattered and knackered, and sure, then you won't be sleeping well and everything else. So, you know, as far as kind of feeling better, you know, really, you know, we can talk around all these things, and we can do blood tests, and we can look at everything else, but God, like, until we actually kind of make a proper change to this weight, you know, we're not going to get anywhere, I think, you know.
No, well, I feel you're not listening to me. I do exercise, I do watch what I eat, and I am very mobile. I'm up at 6 every morning, I work, and I have 3 dogs, and I walk them. And I just feel you're not taking this very seriously, that you're putting all the blame on the weight.
Oh God, Mary, I'm taking it fierce seriously. I think it's very important for your health, and that's why I'm saying, you should be kind of dropping the weight. But like I say the same thing to you every goddamn time we chat, like, and I just don't feel we're getting anywhere. Like, you know, it must be just that you're just not bothered or motivated, you know. Like, would you know, how are we going to change things here? You know, we're just going round and round in circles here, you know.
Yeah, but I mean, I feel you're not listening. I've told you that I'm exercising and watching what I eat, and that I have lost some weight. And I mean, it took a couple of years to come on, so it's not going to come off overnight. So I just feel sort of listening to me would be better than condemning me.
Yeah, okay, well, sure. Yeah, I suppose, yeah, we could there's a few things we can look at as far as the tiredness. Sure, we can, you know, there's lots of different things we can do, but I don't think we're really getting anywhere today. So what we'll do is, look, we'll make another appointment, and maybe kind of you could chat to the nurse and get her to check your blood pressure and maybe check some blood tests and stuff, and then maybe come back to me after that, and we can talk again. Okay.
We'll see. Okay.
All right. Okay, mind yourself. Good luck.
Bye.
Thanks very much for that, Mike. All I can say really is that, you know, how typical is that as an experience? And you certainly wouldn't be getting first place in the membership of the IRCGP examination with that performance. I think many people might identify with that.
Yeah, I think, I suppose the purpose of, we recorded a number of kind of consultations, and it was just to, I suppose, maybe first of all show a consultation that wasn't particularly supportive, and just to highlight some of the issues that people living with obesity or people living with overweight might encounter in primary care. I think, you know, the biggest, you know, thing that I take from that particular video would be the assumptions made by the GP about weight. The assumptions, you know, and these are mirrored in society, the assumptions about people living with obesity, assumptions about their eating habits, assumptions about physical activity, assumptions that they, you know, are not aware of the, you know, potential health consequences of weight, assumptions that they haven't tried and been successful in managing their weight in the past. You know, there's real reinforcement of this kind of oversimplified eat less, move more concept, you know, telling people to lose weight and yet not offering them any treatment or support in doing that. And I think that's very unhelpful. We wouldn't do that for any other chronic disease. We wouldn't do it for mental health. We wouldn't do it for hypertension or diabetes. But yet when it comes to weight, this is the advice that people living with obesity are getting. To me, you know, and we know, and Professor O'Shea, you know, talked about this, you know, living with excess weight is not a willpower issue. It is not a personal choice. It is not a character flaw. It is a complex, chronic, progressive neuroendocrine disease that is genetically conferred and highly influenced by our environment. And telling people to eat less, move more, you know, for weight long term is like telling somebody with depression to cheer up. It's like telling somebody with asthma to take a deep breath and stop coughing. So the idea of the video is just to bring out, and you know, I hope it's not many people's experience, but I fear that it might be many people's experience of dealing with you know, a doctor, and you know, immediately every problem being just blamed on their weight.
I'm afraid historically it is relevant experience for a lot of people, but I really hope that we're moving to a better space. Susie, have you any observations on that, please?
Sure, and I know when we were actually doing these role plays, they're not supposed to be a focus on the clinical actual, you know, interplay. It's supposed to be on the language and the, you know, how the approach is made. And I know it made Mick feel uncomfortable, you know, because that's not his way of how he would speak with his patients. And we know quite many GPs don't speak that way, but there are some who maybe do, and it's unintentional. And we do hear it in our support groups quite a lot from patients, you know, talking about their experiences. I think looking at what Marion, when she was talking there, what happened here was how Mick came in with the discussion straight about weight. You know, he didn't even respond about her tiredness. It was about weight. And this is common, that the weight is blamed, you know, quite often for other problems that you've come, and you know, you mightn't be able to talk about your weight today when you go to your GP. It mightn't be the time to talk about your weight today. So that can be very upsetting for a person who comes for that consultation. The other part there about Marion, when Mick said, you know, are you motivated? There is nobody more motivated than the person who lives with obesity. They live it every day. They have the stigma of it every day. They have all the barriers that come with it, which you'll hear more about later. Every time a person with obesity goes for a treatment, their expectations
are so high that this is it. This is the fix. This is going to be it, because they themselves don't understand about the complexity of obesity. They have self-internalized stigma where they have blamed themselves for years for this. So I think, yeah, and you know what, we'll bring in Emily here when we see that, you know, in Emily's life, she has a list of treatments there that she has tried. So getting back to what Mick said about assumptions, you know, when a patient comes in to have that consultation, there's almost an assumption they've never lost weight before. Right now, I sit here that I'm 17 stone. I was 25 stone. I did get down to 11 stone. If I see a healthcare professional now, will they look at me and say, "My now, Susie, you need to lose weight," not knowing my history? You know, and that is really huge, because how is Emily, in her case scenario, ever going to walk in and have that discussion when there can be stigma about treatments and about regain? I think I'm going to address one of the comments that I saw come in there from one of the attendees, who said about how she was waiting for many years for her treatment and she ended up having to go for surgery abroad. And this is quite a topic that can be the elephant in the room right now, and it is happening widely, of people traveling abroad, and there should be no stigma about any treatment that anybody makes, but they need the proper support. They shouldn't have any stigma about what treatment they get. And hopefully, though, coming back to Donald's talk, the new model of care is going to bring huge changes that people won't have to be faced with tough decisions.
Change is the thing, and we'll go back now and give Dr. Mike Crotty an opportunity to do better, Mike, with a better consultation. And again, I would empathize with the patient, the woman in this consultation, and she was very typical of many of our patients who put up with the care that's there. All of us need to get better at recognizing how we can make it better. Let's go to scene 2, okay? Keep the comments coming, and don't forget the Twitter hashtag, it's on chat.
Hi, Marion. How are you today?
I'm good. I'm good. I just came in because I've been feeling a bit tired in the last couple of months, and I was just a bit concerned when it's not going away. So I said I'd come in and have a chat with yourself today and see what you might think of it.
Yeah. And tell me, anything different in recent months that kind of, you know, could be contributing to the tiredness, do you think?
No. My routine is basically the same, up at the same time, doing the same things, and there hasn't been any big changes that I've noticed. You know, still working, still doing all the things I normally do, but I just feel totally wiped out, and I don't understand that it's unusual tiredness.
And tell me, physically, anything different? Anything feel different from normal, or everything else much the same?
Much the same, yeah.
Okay, and I think I was just, yeah, I think, sorry, I was just looking before you came in there. I know in the past we had checked some blood work and your iron levels had been a little bit low and your blood count was a little bit low as well. Have we done any blood work recently? Do you remember?
No, I haven't had any done for the last couple of months anyway, so.
Okay, so certainly that's something that I think would be worth checking, just to see, as you know, that's a very common problem that can come back, and certainly it can contribute to people feeling very tired. So maybe we could look at kind of booking an appointment and doing kind of, you know, some routine blood work, and then we'll get you back and we'll kind of, you know, a little bit more clearly go through different systems and make sure there's nothing else has changed. Would that be okay with you?
Wonderful, that's great. I really would like that, yeah, but my mind at ease, so.
Yeah. Okay, that's good. Just kind of while you're here, do you mind, would it be okay if I asked you about your weight?
Yeah, no problem, that's fine, yeah, no issue.
How are things at the moment?
Well, I've lost some weight because I have changed things a little bit around and walking the dogs a little bit more, and just kind of, because the weather has been finer, I presume we're out and about a little bit more than we would in the winter time. And but yeah, I'm keeping a close eye. I'm trying to kind of go forward and improve things.
Good. Okay, well, brilliant. Maybe that's something again we can kind of revisit and keep an eye on. You can kind of fill me in down the road. So maybe if you chat to the reception staff and book an appointment for the blood test, and then we can do a full kind of checkup the next time you come in. Okay.
Get some answers. Listen, thank you very much. I really appreciate taking the time and taking the interest. Thank you, and I'll see you again soon.
Not at all. Yeah, lovely seeing you today. Listen, mind yourself now, okay?
God bless. Bye-bye.
Susie, why was this a better consultation, do you think?
Look, I'm just out from the GP now, and he's going to do some follow-up bloods and check going forward by the tiredness and everything. And he was very, very helpful, and I really feel that we will get some answers from this. So I'll catch up with you later on and we can discuss in more detail, but I'm very happy with the way the consultation went. Okay, talk to you soon. Take care. Bye-bye.
Great to be back. So why is this a better consultation? I mean, Mick didn't come in about Marion's weight until after he fully addressed the first issue that she came for. That's first off. You know, he listened to her, he engaged with her, he asked her permission. You know, you could tell there was a different tone, it was engaging, and Marion was open to talking, you know, to him. We missed just a small bit of the first role play where Marion actually had a phone call there. And this is actually quite important because what happens in a consultation can determine what happens going forward, both in a person's day and also for further treatment that they may seek. So on the first one, it was Marion rang a loved one to say, no, it didn't go too well. I'm a bit upset. He wouldn't listen to me. And you could tell her frustration and she was getting angry and she was, you know, I'm going to have to go off. No, I'll, you know, talk to you later. And her whole personality is down. She's going off from this appointment upset. On that one there, you can see the difference. She's happy now. You know, her issue has been talked about. Her weight was asked in a polite manner, whether she wanted to talk about it or not. And, you know, words matter. Quite often when we're in appointments, and this again is very unintentional that people don't realize how words matter. If you hear, did you not know? Have you not tried? Why did you not? Instantly you put a barrier up and you feel this person thinks I'm a bit stupid. This person doesn't think I've ever tried anything before. And you just literally nearly go into yourself where you don't really listen sometimes to what's being said to you during the consultation. Whereas a different approach of, have you tried? Did you know? Can we talk? I'm instantly leaning into you and wanting to listen. You're working with me. You know, because as we come into a consultation, any GP or any healthcare professional may have treated X amount of patients before, but they've never treated a Susie before. So I have obesity, I live with obesity. I've had type 2 diabetes, polycystic ovaries. I have my own list. I have a food disorder. Throw in a little bit of depression, throw in my makeup of who I am, and my treatment is very individual, very individual.
Mike?
Yeah, I think obviously these videos and consultations are not kind of to focus on the medical cause, but more just the approach. I think the listening, asking a question and listening and waiting to hear somebody's answer, actively listening to people. I think looking beyond weight and not immediately focusing and jumping on that. And I think as healthcare professionals, I think that's something we do too often. I think, you know, going through things, you know, somebody feeling heard, them being able to express their concerns. And then at the end, you know, once we had dealt with the presenting complaint, as Susie said, asking the question, you know, would it be okay to ask about your weight? And this brings us to kind of, you know, different tactics for healthcare professionals in discussing weight. I favor something called the 5 A's of obesity management, which was launched by Obesity Canada. There's lots of different, resources available online. And the first thing is actually asking somebody's permission to talk about weight. It's not always appropriate in every consultation. The person may not be in the right place to have the conversation on a given day, but certainly if we ask permission, it's patient-centered. It's allowing the person to control what's going on. And if they don't want to talk, then they can say no, and that's fine. And we move on to something else. With the 5 A's, you know, again, we can ask permission to talk about weight. We can carry out an assessment. There's advising people about, you know, the underlying causes of obesity, from genetics to, you know, medications. And Susie mentioned there in the case study we have, you know, she's on a number of medications that potentially could, you know, contribute to somebody, you know, gaining weight. So these things are quite important, particularly in primary care. I think we prescribe lots of medications. We need an awareness that sometimes these medications can have an effect on those subconscious parts of the brain that regulate hunger and fullness, regulate the kind of reward from food and our body's kind of subconscious drive towards food, you know, all below a level that we can think at. So, you know, all these things are important. We can agree a management plan, we can advise people, we can arrange a follow-up. So I think the 5 A's is a fantastic resource for healthcare professionals. I think as a GP, I'm acutely aware, that it is a difficult conversation. And, in studies of healthcare professionals, we're worried that we don't have the time to devote to this. We're worried about offending people by bringing up their weight. We're worried about kind of not having the right training or knowledge to advise people in an evidence-based way. Potentially as GPs, we're people too. We may have our own personal issues with weight, and we may have a long history of kind of, internal weight stigma or bias ourselves. And we may feel, I know certainly there was a question there from somebody who was a healthcare professional who felt almost hypocritical bringing up weight when they themselves have an issue. I wouldn't feel hypocritical bringing up mental health if I myself have mental health issues. I wouldn't feel hypocritical bringing up blood pressure if I have blood pressure issues. And again, it's about reframing this. This is not lifestyle. This is not willpower. This is not a character flaw or a personal choice. This is a chronic, complex, progressive medical condition that needs evidence-based treatment. And that treatment is not eat less and move more.
I mean, I think looking at the underperforming doctor, it can happen because of fatigue and tiredness and overwork. It can happen because of a skills deficit. The model of care addresses both of those issues really, in terms of definitely bringing in more resources and having a knock-on. Mike, you were very insistent in getting the 5 A's into the model of care, and correct, and thanks for that. We are, I think, getting slowly better at listening to the people coming to us for care. So we'll move on rapidly, as we must, to the next series of consultations. So Colin, who's coming from background of physiotherapy, Sarah Brown, who's a registered dietitian, will lead us into a couple of more consultations. They are mesmerizing, and as I've said at the outset, they are challenging for us. These are complex pieces of communication, so much to learn from them. Colin, take it away.
Thanks, everybody. Thanks for the invite to do this challenging bit of role play. I suppose Carmel and myself went through 2 scenarios, and we'll label them as a more unhelpful one, and then a contrary, hopefully a helpful one. And really, rather than, I took it away from weight altogether, and I think I wanted to go into or explore or demonstrate this, what we call a fixer's frustration. Most healthcare professionals get into the game because they want to fix things. And some things can't be fixed, they need to be managed. I think you can get caught into that trap. So actually, in both of our role plays, I don't mention weight. And I suppose it was just to demonstrate that point. When you're frustrated by a very complex problem and you don't fully understand it, you can end up maybe showing a less pleasant side of yourself. So I suppose, will we have a look at the first one, Maura?
On mute, typical. Yes, definitely. Please go ahead.
Carmel, hello. How are you doing? Nice to see you back.
Hi.
How are you getting on?
Doing? Yeah, just my leg has caused me problems with my exercises.
I think you were telling me, is it pain? You've got pain
somewhere?
Pain,
yeah. It's pain in my knee.
Pain in your knees.
Yeah,
is
and
your
the
left or
leg
right?
gives way. It's my right.
That's your right. And have you been doing the exercises I told you to do?
Yeah, I have. But the amount that you gave in the exercise is too much. I said that to you before.
You've got to push through a little bit, Carmel. It's up to you really to make sure that you get them done. You've got to work that out.
Yeah, but it's very, very hard when the leg gives way.
I suppose it's not going to be easy. Doing the hard things is going to help you. So probably should start doing those.
It's not. It's really, really hard to do.
Well, I think if you kind of just stick to it, see it out, please, and just do those things that I've asked you to do.
Yeah, I do them all the time.
What do you mean all the time?
Like I'm doing the exercise all the time, but I'm not getting the benefits from it.
I suppose I didn't ask you to do it all the time. I said just if you can do them twice a day, just in the order that I told you to do.
But I am doing that.
You think...
Fed up.
Okay, Carmel, we'll look at my recommendation. You keep on going and doing that work, and maybe if you ring me next week, we'll see how things are going.
Right.
Thanks. Now.
Bye. Hi, love. No, I'm not going out tonight. I know we had a plan, but I'm just not in form. Right, talk to you later. Bye.
So I suppose that's a less pleasant version of myself, and I hope just does highlight that sense of frustration and wanting to help at the back of it, but probably being frustrated by the situation. And I think if you look at the feelings that I was clearly portraying, was that I wasn't happy there either, and I didn't want any more to do with this because it wasn't going my way. And then poor Carmel, then you see by her phone conversation at the end, really wasn't in a good place. Now that little bit of her being in a worse emotional state after a consultation, and whether it is because directly the way weight was handled, or in this case her pain, the way her pain was handled, we know that's very impactful on seeking healthcare again. And there's good data on that in regard to gynecological cancers and breast cancers, that people just don't go back to seek care again. And we know that is linked to more serious, immediately serious health consequences. So it is a really, really important thing to get right. If people are seeking healthcare, that we healthcare professionals that provide that in that privileged position must ensure that they leave at least a little bit heard, a little bit understood, and that we have we've contributed in some positive way. Maura, what did you take of that?
Well, thankfully that's not you, Colin, because when I did go out to you with my knee pain, you looked after me very well, but that must have been hard for you to do. Going back to the case study with Emily, I could definitely identify with Emily at 44 with the knee pain. And, you know, people don't realise what barriers there are there for people who are living with a lot of weight. I mean, the stigma when you go outside where people are shouting at you from cars. Now, the way I look at it is maybe there's 5 more people in other cars are saying, well, fair play to her. Like if I go to a car park, will I be able to get out of the car? More importantly, will I be able to get back in again? Or will I have to, as often happens to me, maybe in a hospital car park, I have to ask somebody, please back my car out for me, and that happens fairly regularly. Again, like in that video, you know, you put the onus back on her. You said you have to work that out. I know you would never do that, Colin. So that frustrated her terribly, and you know, as I said, she couldn't work it out. It wasn't going to happen for her, and you know, pushing through, walking more, you just can't do it. You have to take it gently, and you have to listen to the whole background story of the patient, as you know, Colin. You know, she said, you know, she could manage a little bit, but she couldn't do much more, but nobody was really listening to her, you know, and thankfully, you know, most of those consultations are, you know, hopefully gone, but still a little bit there. So it's nice to have this event to bring it to the fore.
And I know somebody like that, if anybody's been through that, they actually feel quite alone, that they're the only ones facing this complex problem. I suppose now will we move on and see the next, hopefully more helpful example?
Absolutely, the time is chasing us. These are mesmerizing consultations, and they really allow us to explore a really important process. Blaze away.
Carmel, hi, it's Colin here, the physio. Nice to see you again.
Hi, Colin. How are you?
What sort of a week did you have?
Tough one.
Oh,
tough one. Yeah.
You had a tough week.
Yeah.
Tell us a little bit more. Was it about your knee pain or was it other things?
Yeah, it was knee pain. You know.
So you have some frustration. I gave you some exercises the last time. Can I ask how they went?
They went okay. They were a bit like I wasn't able to get them fully done each time because the pain was kicking in too much. Okay. But I did follow what you said.
Oh, that's well done. I suppose sometimes the same group of exercises won't work for the same patient. Would it be okay if I had another go and designed a new little exercise sheet for you?
Yeah, that's good.
Well, I'll work on that and I'll email it to you. Maybe some things that other people have found that has helped them.
Brilliant. I'll try that.
Very good. Well, I'll email that to you, and listen, good luck with it.
That's great. That's brilliant. Thank you.
Thanks, Neil.
Maura, what are your takes on this second better effort?
Hi, love. Yeah, I'm just finished it there. Yeah, it went well. I'm feel upbeat for trying more. I'm looking forward to tonight. Yeah, it's been ages. Okay, see you later.
Yeah, my take on that is that people living with obesity, we are motivated. We want to do what we want to do the best for ourselves. Like, we want a quality of life. And Colin really engaged with Carmel that time. Like, he's given her hope. He's going to, email her a new program, which is, giving her great ideas. Hang on, I'm going to get something new here to do. And then, like, short bursts of walking. Like, when Colin told me you need to do kind of 30 minutes a day walking, but break them up into 10 minutes each time. I never thought of breaking them up into 10 minutes each time. I think that was a very good consultation. And like Emily, I'm living in a rural area, so it's very difficult to find places to walk. Like, I would get in my car and drive to a place to walk. So there are barriers there that people living with obesity face, and finding out the barriers and dealing with them and finding the whole issue is the best way forward, in my opinion.
I suppose my thoughts on it there, Brendan, is that the Hollywood actors are safe enough. Acting wouldn't be I wouldn't be shining there. But listen, I thought for me, again, with these complex presentations, pain and the disease of obesity, again, the one thing I do here is that people feel alone with it, that it isolates them. And I suppose one bit of that social relatedness concept that you can bring in, that really does, I think, help others or help patients. When you talk about what worked for others, I'll try this one. This is something other people have found useful. I think just little ways in your language like that can be helpful. At least that's my thoughts.
Absolutely, you would both get awards for reality TV, because this is it really smacks of real life consulting. My own observation on the good consultation was it was actually very short. You had correctly identified the patient concerns, you were able to address them. There was clear connectivity between the two of you. We often think in healthcare that consultations have to be really long, and we're stressed because they can't be. But it's a terrible thing to say, but you nailed it there in terms of listening and responding.
And there was no blame attached in the second one. It was perfect.
And the bounce carried on to the telephone conversation, which was really lovely to see. The energy comes out of the consultation.
Absolutely, yeah. The good feeling afterwards. The hope that things will be better.
Exactly, and the feeling of support. I think that's the key bit, isn't it?
Yeah.
Well, yeah, and you see agency. There's agency coming out of it. Yes, I can get on.
And just to get a little bit of advertising in, the Irish Coalition for People Living with Obesity are on Facebook. ICP Obesity, you have to get that in.
ICPO on Facebook. We're not rushing that.
We're on Twitter. And we're building a website. That's in the offing. Exciting times ahead. Don't be alone. We're there for you.
Thanks, Al.
Thank you.
Perfect. Thank you so much. So we're moving on, and we have some more consultations coming up. And again, there's a lot of commentary coming in on chat and Q's and A's. We're falling seriously behind in Q's and A's, but we will have an opportunity to rush and catch them up towards the end. So do keep them coming, and do keep the activity on Twitter coming. I see Karen has put up the Facebook and link to ICPO. And certainly, I think more of us increasingly, I know in my own practice, I'm directly referring people onto ICPO. It's a fantastic support source, guidance, knowledge, and experience, and it's very, very validating. Just if I can just take guidance from Helena or Karen, and where are we going to next?
So we're now going to welcome Dr. Sarah O'Brien.
Sarah, which is wonderful.
Hi, Brendan. So Sarah Brown, and I'm going to introduce our next video, and Bernadette is also going to join for the discussions afterwards. So in this scenario, again, we have two sort of scenarios played out, and it's where two parents are checking in with a healthcare professional to discuss their concerns about their child's weight.
Hang on.
Don't forget we have that doctor's appointment later today.
What doctor's appointment?
The one where we're going to bring our son, talk about the issues we think he's having.
Okay, what's the point?
Because we need help. We can't just let it continue.
But why? They never tell us what we want to hear. They don't want to help.
Well, we have to go and try.
Yeah, okay, whatever.
Hi, Deirdre and Alan. I'm Sarah. Welcome to your appointment. Can you tell me a bit about why you made this appointment today?
Yeah, so we have some concerns about our child's growth. We feel his weight is going up higher than it should be, and he's bigger than most of the peers in his class. And we're just wondering, like, is that an issue that we need to look into, or is it kind of something he'll grow out of?
Okay, so you're worried about your child's weight, and have you had it checked out?
We've measured him ourselves at home, his height and his weight, and he does fit into the obese category.
Okay, so it does sound like he has a weight issue, but you haven't brought him to the clinic or anything?
No.
No, okay. So we would need to get him in soon and just get him checked and, plot him on the charts and have like the doctors and the nurses look at him, and then, if necessary, send him over to the dietitian as well. So
his diet is quite healthy.
Really?
Yeah, like he eats a good bit of fruit and vegetables.
Yeah, like a lot of especially with kids, a lot of high fat and high sugar food can really creep into the diet that you may not be aware of the level that he'd be eating.
No, we're pretty good at that kind of stuff and keeping track of sugars and fats and so on.
You should, because it'd be unusual for a child to be, in the obese category if that's the case, and they, when they would be eating healthily, if that's what you think healthily is yourselves.
I mean by think healthily.
Sometimes what we think is healthy isn't necessarily good for children.
Well, we don't think McDonald's is healthy. We're not feeding him burgers and chips every day of the week. He eats fruit, he eats vegetables every single day. He drinks his water. He
eats his 5 a day. He goes out and plays on the green. He's on a scooter. He's on his bike. He's
very active as well.
Yeah, you probably with the diet now, you're going to definitely need to have a full assessment.
Okay.
Yeah. Really have a look into the detail of it and see where all of those food, where the types of foods that he shouldn't be eating maybe are getting in.
Okay.
He doesn't eat junk, and he doesn't drink fizzy drinks. He drinks water.
I just don't know how he'd be, in the overweight obese category if those foods really weren't getting in somewhere.
Yeah. Okay.
Right. Well, he's very active, so surely that helps.
Yeah, absolutely. And a lot of kids can be active but just don't get what they need. They need at least an hour, if not more, a day of good activity.
Yeah, no, he'd easily get that out on his bike and his scooter and running around with his friends and out on the trampoline.
Schoolyard, at lunch break.
Yeah,
it still mightn't be enough,
Well, what's enough?
He has an issue with his weight.
Like, if it's an hour and we're saying he's getting an hour and you're saying that mightn't be enough, then what is enough? How do you determine that?
Yeah, I think if we talk about it a bit more when you come in and we, just kind of dig a bit deeper and see.
Yeah.
Yeah. Okay. Yeah, okay. We'll leave it there for today. Thank you. How do you think that went?
Waste of time.
Yeah.
Not listening to those usual crack,
I know. She kept asking about the diet. His diet's fine.
I know, but sure, no matter what we said, she didn't want to hear it. Like,
no.
Apparently we're wrong.
Yeah, nothing is enough.
Yeah.
What's he supposed to do? Exercise 10 hours a day?
Apparently so, yeah.
Yeah.
Mm.
Yeah. Just didn't listen, did she?
Not at all. Yeah, won't be going near her again.
No.
So essentially in this role play, we're seeing what could be considered a critical moment, like one that might predict these parents' future engagement and support seeking, and one where the healthcare professional can build like a rapport and a trust with the family. And in this scenario, I felt very uncomfortable about not listening to what the parents were telling me. And they were repeatedly trying to tell me about their child's current patterns and behaviours. And in a sort of pseudo nice or concerned way, I was saying they weren't very insightful about their family's behaviours and their own routines, and that the healthcare professionals would need to come in as experts and investigate this more. I think this is very challenging for parents who, you know, are already feeling vulnerable and judged in anticipation of the appointment. And what's happening, instead of creating a safe setting where their concerns about their child can be raised without fear of sort of negativity, Alan walks off and leaves Deirdre to close the consultation, and afterwards they feel blamed. So implying blame, I think, can be very subtle, and we need to be careful about this as healthcare professionals. And even just linking into the Emily case study, we also need to be mindful of all of the things that are going on within families, you know, that parents might have their own health issues, and they're juggling multiple and complex issues within a family scenario. Interested to know what Bernadette thinks as well.
Yeah, I agree, Sarah. It's, you know, it can be very difficult for parents. First of all, Alan didn't necessarily agree first about about having a consultation. He didn't seem to see that there was as much of an issue as Deirdre did. And, you know, that can cause kind of friction between the parents to begin with. And then when they are trying to explain to you how their child eats, what exercise they do, you know, and this, you know, I suppose the idea that kind of they're not being believed as parents, as in what they give their child, what their child does, it can be very, very negative. And obviously it can put the parents off actually seeking help for the child. It's like you say, this is not about just, you know, unfortunately, when you're dealing with an adult, dealing with obesity and overweight, you're dealing with an adult. When you're dealing with a child, you're dealing with the family, you know, so it's a lot more complicated in that way, you know. And I think you really do kind of need to listen, because the frustration can make it difficult to return. I suppose, like, this is where Emily comes into it as well, where in Emily's family, she has one child who would live with overweight and obesity, and 2 children that don't. Now, the usual thing is a mother is going to feed their 3 children the same foods, you know. And why does one of her children have an issue? But then Emily herself is an issue. So therefore, is it more than just the food? Is it genetic? You know, there are so many things there. And of course, what you were saying as well about where the parents are health-wise, even mental health-wise, you know, it can be very difficult if you're trying to deal with your own issues to deal with your child's as well. Even though as parents, we will always try to put our child first. But you pretty much need to be in a healthy state to kind of get, you know, to talk about it properly, about your child and kind of where they are and what this will do to them. You know, even children as young as 3 have been, you know, called names in the playground. It's come up in studies recently how young it's beginning to start because of their weight, because they are maybe slightly a different shape than their peers. And by the time then that you get to adolescence, you've got the whole self-image coming in there, and that, you know, so that's why it's very important to catch it, you know, where we can kind of instill the confidence to change things, maybe if anything needs changing, in baby steps. So you don't set the child or the family up to fail. That's so important that, you know, that's really kind of where we need to come from, I think, with this.
These are short clips, but they really strike true, and they really reflect the busyness of real practice as we see it. Certainly in the consulting chair, from our perspective, you often are blind to the idea that people prepare and think and worry before they come in. and also that they have their own debrief and consultation and discussion among themselves when they go out. Such it is. Particularly, we know that historically availability to dietitians has been very limited. Often people have to travel, and that just puts extra stress in the consultation. In terms of the model of care, Sarah, you're aware that additional dietitian capacity is being built into the system. Do you see that making a difference in the years ahead?
Absolutely, yeah. I mean, I think families are very often looking for guidance around eating behaviours. Not necessarily, a lot of people know around what healthy eating is, but sometimes with children and adolescents, there's tricky eating behaviours as well, and dietitians would be well trained in that area. So for both the food and the eating behaviours, I think it'll be a positive thing.
Actually, I'm just going to come back in on that one for a second. When I was saying about dealing with the family, I think kind of the issue as well is not singling out the child that has the issue. So I think it's very important to make it about health within the family. And it's good for everybody as well, because just because you don't maybe visibly have an issue does not mean that you're healthy on the inside either, you know. So I think kind of making it a health thing for all the family to do together. You may spend more time together as a family. You know, you cook together if you have the time. Obviously, practicalities come into it. We do realize, but you know, just as I said, work on it as a family rather than focus on the individual, because it can be very difficult on the child who's singled out.
And I think it'll be easier for the child if the healthcare professional establishes a really good relationship with the parents as well, a trusting relationship.
Absolutely, because I was just going to say, the parent, if they've lived with it their whole life, they may have memories of when they were younger and how things were different. So what you want to do is you want to instill that confidence that they can trust the person that they kind of bring their child to.
Absolutely, yeah.
So it is complex, it's difficult, there are historical issues, but it is very much a moving situation. And the insights we're sharing today, we do hope we're going to see them operationalized. We are going to see these differences. The extra dietetic help is going to make a difference at the consultation level. And certainly in the diabetic program, and the diabetic model of care has been going for a few more years. Certainly dietitians have made a huge difference at a practice level in terms of engaging with general practice nurses and GPs. So for a variety of different reasons, you know, I think we can allow ourselves to just be a little bit more optimistic that the situation, the concerns that we might have. Any last words on that, Bernadette, Sarah?
There's one more video to watch, Brendan, so we might watch that and come back. Hi, Deirdre and Alan, how are you?
We're good. How are you?
Great, thanks. I'm Sarah, and thanks a million for making the appointment today. Do you want to tell me a little bit about what's been going on and what you'd like to talk about?
Yeah, so we're not sure whether, you know, we need medical help or not, but we thought we'd come and check with someone like yourself. So we're concerned about our child's weight, and that he's a little bit bigger than children in his class, and maybe he's growing a little bit faster than everybody else. And we weren't sure whether it would be a concern we should address now or whether he'll just grow out of it.
Okay. So you've noticed that your child is larger than other kids his age, and it's just something that you'd like to get checked out. Have you discussed this with anyone else before? Is this the first time to look into it?
We've discussed it before, but we've generally had negative reactions that it's been our fault, and it's, you know, he's not getting enough exercise, or it's what he's eating, you know, and what we're feeding him as parents. So we're a bit reluctant to bring him to any appointments.
Maybe he's quite healthy and he does get a fair bit of exercise.
Okay, so it sounds like he's a happy, healthy child for his age, and that you're concerned he might be carrying a little bit of extra weight just for his stage of growth. Yeah, so in terms of the next steps, I mean, I suppose for me to understand how your child is growing at the moment, in terms of both his height and his weight, we would need to get him checked out in person. And so what that would involve is just bringing him into the clinic, And we'll have someone who's trained in measuring children in terms of their growth for their age and their sex, and see if that's normal for their stage and their age. And so if you're happy, we can arrange a time to do that. And in addition, we could also talk a little bit today about any other concerns you have around your son's growth.
Okay, yeah, that sounds good.
Yeah.
So is it all about kind of eat less, move more, or is there more to this?
There can be. It really depends on what level of extra weight a child might be carrying for their age, and that's something that I can't sort of make a judgment on today. One of the main things is that your child is growing well, they're developing well, and that they're eating well, and they're exercising enough for their stage. And it sounds like your son is doing all of those things. So it might be reassuring just to get his weight checked and see where he stands at the moment.
Can you tailor exercises for him? Like, he has hypermobility and he mightn't be able to do everything.
Yeah, so we do have a specialist physiotherapist who works with us here and has a lot of experience in, talking to children and their families about exercises, and we'd be more than happy to refer you there if that's what's needed as well.
Okay. That's all very positive. Yeah.
Yeah, so why don't we arrange an appointment?
Yeah.
And maybe see each other in person and talk more then.
Yeah, that sounds good. Great.
Okay, thanks a million.
Thank you. So how do you think that went?
Yeah, better than I expected.
It was good, wasn't it?
Yeah, it was. They actually listened for a change.
Yeah.
Nice.
I know, and they didn't blame us.
Yeah, true.
Yeah, it's great, isn't it?
Yeah.
I'm going to make another appointment now. I'll go on to that first thing tomorrow morning.
Yeah, do. Let me know. I'll tag along.
Great.
Completely different experience. Bernadette, what would your take be on that? Was there some amazing magic or complex thing that happened on the second take, or why was it a better experience?
Well, even just hearing about kind of your child growing, can take away some of the blame from the parents, because presently a lot of it seems to be that if a child has an issue, that you will watch, as they grow, that they don't gain weight, that they pretty much grow into their weight almost, and that can be far more positive for a parent, because, as I said, it takes away a lot of blame, and that's really important, especially if you want a child to return with their parents. Very important in that way. But we can definitely see the difference with both parents there, but particularly Alan. Alan seems to be more kind of in with the whole thing of, the positivity. And I suppose a healthcare professional is very important in that way as well, in that, as I said before, that kind of there can be issues between the parents on kind of what way they see these things. But sometimes if the healthcare professional aims it at the right way, they can bring both parents on board together, which is great.
A huge amount to like in the second take, and also from a gender-based perspective, it's really nice, and we see it in practice increasingly that men are becoming a little bit more involved in terms of household dynamics and beginning to take a little bit of responsibility and ownership around health. Sarah, what were your responses to the second take?
Yeah, I suppose here was a chance to put the family at ease about investigating their child's growth. And if I had to say something else to them, I would say you're doing the right thing by checking this out and having this chat before you're bringing your child into clinic, because no parent wants to expose their child to a negative experience. And I think Bernadette's point earlier around mental health is so important, because a lot of children and teenagers will have been bullied about their size at school or in other sort of situations with other children and indeed adults. So we as healthcare professionals need to be very conscious with our words, with how we conduct ourselves, with the practicalities of how we interact with families. Like, for example, explaining about how the measurements work and why we're taking them, using sensitive language and talking about growth, development and health, rather than focusing solely on weight.
Bringing it back to an older child again as well. As we saw, Emily is actually on mental health medications. An adolescent or even a younger child might be as well. and that could have an issue with their weight. And again, it's just something that needs to be taken into consideration. But just as a point, we actually had a dad reach out to us recently about their child and how worried they are about their child, how to approach this within ICPO. And I suppose that's what we do mostly, is by having support meetings when people come. Our lived experience as parents, as adults, you know, it kind of helps others to realize that they're not alone. And they could maybe learn something from one other person who's been through the same. And I think this is kind of where the support is needed, as well as kind of seeking help from healthcare professionals, that if you've got the two in tandem, it kind of works so much better, I think, you know, for everybody.
So there are a couple of things that need to be there. So it is a little bit complicated, but it's not unduly complicated. Several of our conversations have identified the difficulty around eat less, move more. For decades, a lot of us felt that's all that we had, and didn't feel happy about it, understood it was admonitory and judgmental, and that it was of limited or no value. But with the model of care and with the amazing breakthroughs that are being made around medication and bariatric surgery and better multidisciplinary focus, really the time now is to move on and to have these. This is about having these conversations, having them earlier, not around a crisis, and having them with kindness and with common sense. Sarah, have you any other observations here?
I also think, just for parents and members of the public who are here, that, you know, with children and adolescents, you know, sleep, you know, psychological supports, and maybe specialist sort of movement and eating behavior supports can actually make a difference. So that sort of does shift the focus slightly away from just eat less and move more, just to have some additional supports in place that might be very helpful for the children's overall diet and kind of physical activity patterns.
I agree on that. I was just going to say, because screen time obviously has become quite an issue as well, in kind of, especially over the pandemic, but even before that, you know, so it can interfere with sleep or whatever. So maybe kind of have regulations in your house that the internet's off at a certain time, you know. Again, it takes away from kind of eat less, move more. It's more about just healthier choices, you know.
So it is bringing common sense to bear, hopefully with a health system that is more attuned, that we've got a clearer idea of what's likely to make a difference, and that we can move from either ignoring or being in a terrible welter of anxiety and defeatism about it towards doing, well, the simple things well, and following up in consistency, and that you've got that continuity, the right piece to bear. So these things are important. I'd refer you on to chat as well, where there are additional resources going up. And I'd also refer to anybody who's responsible for running a home, the Safe Food website, where there's a lot of really good concrete information around nutrition in a way that actually makes sense to an Irish household, if such a thing could be said to exist. In devising these videos, they have been an amazing set of scenarios. I think they speak very powerfully to all of us who are listening, and I would really like to acknowledge the expertise, the experience, the knowledge and the wisdom of ICPO in bringing these. They are an amazing teaching resource for us this afternoon, and I suspect that they would work brilliantly well as training videos for any healthcare professional, whether you're in nursing or medicine or dietetics or physiotherapy, that they would be of enormous value. They're so authentic, so an enormous thank you to all of the patients and everybody who's assisted in their production. There's the Safe Food website, and also it's on chat, and also there's quite a lot of activity going on Twitter, and again the Twitter hashtag is there on chat for you. We are moving on, and we're doing well on time, I would hope, and we're moving on next to an audio experience with Cara. Again, in this, we're really sharing real life experience and emotion and thinking in relation to this really important issue of overweight and obesity. So we'll move on to that if we have it.
Hiya, Cara. It's good to see you. I haven't seen you, I think, in probably maybe 2 years since we were at a family walk. It's really good. I'm delighted you've decided to chat to us today, and I know your mum is there in the background watching too, so you're not on your own. Cara, last year we had a campaign, and it was for about people who live with obesity, and we made a magazine, and you were really good that you gave us a quote for the magazine, which I'll read. It said, "Not everyone who eats fries is overweight, and not everyone who is overweight eats fries." And I was so amazed by your quote. I thought it was fantastic. Is it difficult, do you think? Would you like to chat to us about how it feels when people assume that maybe people who are overweight eat fries? What do you think?
It is a bit hard sometimes because there is a bit of a difference between me and my dad, because my dad can eat whatever he wants, no matter how much sugar, how much fat, and he'll stay so thin. But I could eat like 5 jellies and I'll put on more weight. So it is hard to think about it like that when I know people think that I would eat way more than my dad, when my dad eats way more than me.
Sure. Okay, so that's hard. And I know that you've been in touch in the last while with a healthcare professional to chat about your weight. And do you find this has been useful for you? And is there any points that somebody has said something that you've thought, oh, that makes sense for me now?
Yeah, there have been. There's been one where I've been told that because of my weight, I'm quite insecure. So I've been told that if I think someone else is judging me, they're probably thinking when I'm looking at them, I'm judging them. Okay. So it's not that a lot of people are judging you. You're all just thinking, you're all just judging each other. So it's not just you in this boat.
Sure. I love that, Cara. Yeah. Is there anything else that you think that you wish your friends or your family would understand about your situation, or do you prefer not to talk about it?
Not really, because my mom kind of gets it and my friends don't question it at all. So
that's fantastic, isn't it? Yeah.
Yeah.
So is there anything you can remember that maybe a doctor has said to you that you didn't like, or is there something that a doctor said that you really liked? Does anything comes to mind?
One that I didn't like, I had a cough when I was a bit younger in primary, and my GP said, are you the biggest in your class? And because I was really young at the time, I said, no, a different girl was the tallest. And he said, I didn't ask who was the tallest, I asked who was the biggest.
Okay.
So that did quite upset me.
And were you able to chat to your mum about that afterwards and chat to somebody how you felt?
I didn't get it at the time, but thinking about it, it is hurtful. But I know that my granny was with me, and they were both just mad because my mom wasn't there.
Yeah.
But my granny told my mom what he said, and she wasn't happy at all.
And what do you think nowadays is better? Do you think people are starting to learn more that it's no different to any other thing that people can have going on with their bodies?
Some people, yes, some people no, because I've been to that GP a few more times after that, and he still would just ask what my weight was and just tell me to lose weight. So.
Sure. Okay. Cara, is there anything you'd like to say as a last word before we go? Anything at all you feel like sharing? No. We really thank you very much for talking to us today. And we did say we keep it short, so thanks a million. Talk to you soon.
No problem. Bye.
And I mean, again, there is the breadth in what we're trying to do, and we've heard adult voices, and it's really, really important and a pleasure to listen to Cara's voice and her perspective that she's articulated so brilliantly well, and under the fantastic guidance of Susie Burney. Susie, have you any observations or comments to make in relation to Cara's experience?
Hi, Brendan. Just that she was one fantastic girl. I mean, she has such insight at her age, and a positivity, but very difficult for her, at that age. And her mum, is well up on all of this too. But she really pointed out the complexity of her father being underweight, and people who would assume that the parents maybe, would have the blame of, the family situation, and yet her father's with underweight. And then also the GP saying, are you the biggest in the class? I mean, that sort of narrative has to change, but I thought she was fantastic, Cara. She was great.
Sometimes these comments come across carelessly, they pop out carelessly, sometimes they come out under pressure. Sometimes it is an absolute lack of skill. And also
that is something we want to keep repeating, is that we know a lot of it is unintended, and that's why we just need to raise awareness. Very much unintended, but you know, words really can matter. And that old saying, sticks and stones, is rubbish, because there's many of us can think back to words that have been said to us in the past. So if we can change the narrative, if we can get people to think a little bit more about what they say before they say it, we're going to start winning.
I think we are, and I think we'll do that. One last thing I would say in terms of why these comments sometimes pop out, a lot of clinicians actually do have a serious concern about saying what is the right thing, and sometimes you just really put your foot in your mouth. So we just have to ask for apologies and forbearance and a commitment to do better with this.
Sure.
So we will move on, and I think we have Niamh Arthas coming to us. Niamh's disciplinary background is dietetics, and Niamh works closely with another fantastic team, multidisciplinary team, RCSI Temple Street and Sláinte Care, and is involved in Weight to Go, I have no doubt, and a whole lot of other things. Niamh, can you lead us into what we are all now looking to, building capacity, and particularly around childhood overweight?
Yes, indeed. I'm just trying to share my screen.
I think we can see it. It's looking good.
Great.
And your slide showing fantastic.
Lovely. Thank you very much, Brendan. So yeah, I'm going to start us off on the theme of building capacity for child and adolescent obesity treatment in Ireland. And I'm going to focus on the Sláinte Care project and then hand you over to my colleague, Louise Tully, who's going to bring you through the Landscape project. I'd like to start just by giving a bit of background on childhood obesity in Ireland. At the moment, according to the most recent COSI, which is the Childhood Obesity Surveillance Initiative data, 1 in 5 primary school-aged children in Ireland are living with overweight or obesity, and around 80,000 children in Ireland have obesity. International health research and clinical guidelines recommend multidisciplinary treatment early in life in an effort to reduce health complications and the risk of future disease. And we know from the literature that children and teenagers who have obesity are at greater risk of having obesity as an adult, and they are at greater risk of having complications of obesity as an adult. So really, you may be listening in today as a parent, as a grandparent, as an aunt, an uncle, a teacher, or a healthcare professional. Children are the future of Ireland, of our country. So this is everyone's business. Professor Donal O'Shea mentioned earlier on that the focus of Sláinte Care is the prevention of disease and integration of health services in the community. And RCSI and the Weight to Go service and Children's Health Ireland at Temple Street are supporting the implementation of Sláinte Care by increasing the access for health professionals to childhood obesity training. And the Sláinte Care Childhood Obesity Project is led by the remarkable Dr. Grace O'Malley, who is also the clinical lead for the only national paediatric obesity treatment service, which is the Weight to Go service in Children's Health Ireland at Temple Street. And she leads the obesity research and care group at RCSI. So I'd like to propose this question to the over 540 of you tuned in today. Now don't come off mute, you can just type it in the chat box, or please engage on Twitter. Are you interested in maximizing child health and development? And if you are, hopefully you'll support our work with the Sláinte Care project and our Landscape project. So our Sláinte Care project objectives were to develop and deliver training in childhood obesity for healthcare professionals, to establish a community of practice for those treating children and adolescents with obesity, to reduce inappropriate referrals to hospital-based childhood obesity services, and to support improved communication in clinical encounters with families and minimize stigma. So far, we have exceeded all of our deliverables, the first being by increasing the availability of training in childhood obesity to healthcare professionals in Ireland. Our target was to increase this access to training to 78 healthcare professionals. And today we have 837 enrolled in our online free and CPD accredited childhood obesity training course. And over 500 of these indicated that they had no previous access to training before our course became available. Another deliverable was to increase by 50% the hours of training in childhood obesity received by healthcare professionals. And this is compared to the previous 24 months. And again, we exceeded this outcome by an increase of 364 hours. And that's actually probably more now at this stage, because that was the amount that had increased by August 30th. Another deliverable was to increase the level of self-efficacy in assessing childhood obesity. And we used a Likert scale. So our target was 4.75 out of 10. And of those who completed our core module, 357 rated that their knowledge has increased to 7.75 out of 10. And finally, our another deliverable was to create a community of practice for childhood obesity. Our target was to reach 20 healthcare professionals. And today, and growing, and we still welcome more interest, we have a total of 769 engaged in this community. So pre-COVID, another deliverable was to deliver training in childhood obesity to 40 healthcare professionals in Ireland. And then because of COVID and the European and International Congress on Obesity went online, just as we're still online today, we were able to increase this access from 40 to 216 healthcare professionals in Ireland who received training in childhood obesity over the 4 days of this Congress. And we conducted a survey that assessed knowledge pre and post this training, and 61 professionals completed that survey and indicated an increase in their perceived knowledge by receiving this training supported by Sláintecare. So in order to create and develop our online childhood obesity education program and to tailor it to the needs of healthcare professionals and health services in Ireland, we first conducted a needs assessment survey. We invited all healthcare professionals in Ireland that see infants, children or adolescents, and those who are interested in childhood obesity to complete this online survey. We had 779 respond and share their insights, and we used this along with clinical guidelines to develop a culturally appropriate online childhood obesity training program. And this can be accessed through our website, which is childhoodobesity.ie. And also on the website, we have a fantastic array of resources for healthcare professionals, for parents, and for young people as well. So if you click the resources section there, you'll be able to get access to those. And also you may be, if you're interested in this area, you may be interested in our news items from time to time. So do keep an eye on our website. As I mentioned, our online training is free. It's CPD accredited. There is a mandatory core module and 4 optional advanced modules. And each module offers 1 CPD credit. So you can get a total of 5 CPD credits by completing these modules. To date, we have 837 enrolled, and 401 of these have completed our core module. And it's been really well received so far. We have an average course rating of 5 out of 5 stars and a satisfaction rating of 9 out of 10. So if you haven't done so, please use this as an opportunity to access this training. I won't read out each of these reviews in the interest of time, but I'll just pick one user review of our course. I honestly thought this was a wonderful course, a wealth of information and resources that I truly feel all of us as healthcare professionals working with children should complete. Excellent work, well done. And we really want to extend our appreciation for everyone who has provided feedback, really valuable and rich feedback on our course so far. Finally, I would just like to acknowledge each of these organizations displayed on the screen, to whom the success of our project would not have been possible without, and of course, to each and every individual on this screen who is our Sláinte Care project team and our collaborators. So Gurv Mila Mila Malgav Galer, and thank you so much. I'm going to pass over now to my colleague, Louise Tully, to tell you about the landscape study, which follows on from our Sláinte Care work. So over to you, Louise.
Thank you very much, Niamh. 1 second. Hopefully you are seeing my slides now in a moment.
They're looking very well, and you're on slideshow. That's fantastic, Louise.
Great. Okay, hello everyone. Thanks so much to the organisers for having us, especially the NCP, ASOI and ICPO. As Niamh said, I'm Louise Tully and I'm also a researcher within the Obesity Research and Care Group. So I'm going to present some information relating to another study we're undertaking, and it follows on quite nicely from what Niamh presented around the Sláinte Care project. So this project is part of a Health Research Board Applied Partnership Award. So it's in direct collaboration with the HSE. So the aim of this work is to generate relevant data and resources to support the implementation of obesity treatment services for children. So as you can see here, there are an array of components to this study. So work package 1 is very much up and running. So that's the first 2 kind of cogs you can see in this wheel. So the very first piece of work has involved a review of the clinical practice guidelines for the treatment of obesity in children and adolescents. So this piece of work is at the end stages of write-up, and we're hoping to submit it for publication very soon. We also hope to then disseminate and summarise the current recommendations in a way that might be useful and accessible for various health and social care practitioners to easily identify what the current recommendations are for within their remit or within their setting. So work package 1 aims to look at not only what is recommended, but then also what is happening. So for the second part of that, we're also in the middle of a large survey to assess the current picture for child and adolescent obesity services and what that looks like nationwide, or assessing the current landscape, if you will. So whilst it might seem like a piece of work like this is likely to tell us what we already know, i.e. that services are scarce or non-existent. This is an opportunity for us to demonstrate that with hopefully nationally representative data to really make the case for change. And I suppose secondly, though specific obesity treatment services might not be up and running, there's an opportunity for us to capture the little pockets of support that healthcare practitioners might be offering out there that we don't know about, and capture that. They might be offering it through different services like disability services or community dietetics, and it'll just give us a picture of what's going on. So the second work package then, this will involve focus groups with health and social care practitioners as well to explore the detailed barriers and enablers for providing care to children with obesity. And also we hope to do like a prioritization exercise with the groups for addressing what the current practice needs are for right now. And then we will aim to collect quantitative and qualitative data with parents, carers and families around their experiences of navigating obesity treatment services. And then the final stage will involve developing a framework of recommendations based on all of that work around how we can identify steps towards implementing the model of care for obesity specific to paediatrics. So first of all, a summary of the methods for our guideline review are shown there, just to show you that it was a systematic process, but to briefly summarize what we found. So the current guidelines, which were found to be high quality, they predominantly recommended the delivery of tailored, family-orientated, multi-component interventions aimed at improving nutrition and physical activity. So around treatment outcomes, then they were generally focused on measures of adiposity, so measures of weight, and there was less emphasis on management of complications or improving quality of life. So that's one gap we identified. There was also no evidence-based consensus on the mode of delivery that's best for treatment or the best format. And also few recommendations focused on addressing the practical or social barriers to behaviour change. So things like cooking skills or supervised physical activity. So there's also a notable lack of evidence reported for surgical and pharmaceutical interventions in children, and so they generally weren't recommended. So we're aware that many of the included recommendations are currently being updated, and hopefully, as new guidelines emerge, they will factor in some of those considerations that have been missing from the previous iterations, I suppose. So in terms of our survey then, we've had over 110 health and social care professionals fill it so far, but we're very much still collecting data. So please do, you know, if you're eligible, please do complete it if you see children and adolescents in your daily practice. We're missing, you know, we could do with more GPs and some GP nurses, for example, to represent what's happening on the ground there. And I'm not going to present the quantitative findings collected so far because they wouldn't be representative, as you know, we haven't finished collecting data and we wouldn't do the analysis justice. So what I have done instead is I've presented some of the open-ended responses that we've received. And when I say presented, I've summarized them very much in these bullet points. The data have not been analyzed formally in any way, but there are definitely some clear threads coming out. And it's that piece around, you know, the barriers. So now, this certainly doesn't cover the breadth and nuance of what's been reported either, but I just thought it was maybe nice to summarize a little bit. So one quote from a participant that I think kind of sums up a lot of the responses: "I'm not aware of the services that I can refer my patients to for weight management. I see children who are overweight from time to time. However, I do not know how I should acknowledge this with the family, and once acknowledged, I would not know what intervention I could put in place." So I also wanted to share another one that came in. I wanted to draw attention to this response as I feel like it represents possibly the views of a lot of people out there. So this person says, "Children do not need to be measured or put on diets. Diets are not effective. A health at every size approach should be taken. We can encourage health promoting behaviors such as eating a wide variety of foods and engaging in movement that we enjoy without needing to focus on numbers." And then the person went on to talk about the other systemic issues. And rightly so, there are many systemic issues and obesity is complex. So I completely agree with this person that the child's enjoyment of food and movement should be front and center and absolutely not a focus on numbers. But I also think this viewpoint is massively important because it demonstrates the common perception that obesity services entail putting children on diets. And I think as we continue to address the gaps in education in this field, and in particular around stigma and the complexity of obesity, we can help to move to a place where treatment services are very much around improving a child's quality of life, and also a place where that's well disseminated. So lots of harm has been caused in the past by, maybe if you think back to the role plays, and also if you think about Emily, who, you know, has a child living with obesity and she's tried everything, she might be very reluctant to have her child sign up to something that might cause harm in the way that perhaps she has been treated in the past. So engagement with a family or child should never center on numbers, but instead whether they are able to take part in the activities with their friends, for example, that they want to participate in. So that's where the Edmonton obesity staging system really plays an important role, because it differentiates children who maybe simply live in larger bodies but are happy and healthy to those that might be experiencing complications or comorbidities for which maybe they would benefit from support for. So as we continue to collect data on the current situation, it will be really important for us then to look forward and think carefully about how we can maximise the information we gather to inform service development. So Niamh has already hopefully directed you to this website, so childhoodobesity.ie, and then if you go /news, you'll find all the information about the landscape study. And if you're a parent or carer, or you have a child in your family that might be affected by obesity, do keep an eye on this as well, because for the next stages, we will be looking to hear from anyone with any experience of navigating childhood obesity services, or you're welcome to get in touch with me before then, which is louisetully@rcsi.com. So thanks to everybody on the landscape team who are named here, but also special thanks to past members of the Obesity Research and Care Group and Way to Go teams, including Dr. Kathy Weiss, Dr. Sarah Brown, Lois McCree, and Lucinda Case. Thank you.
Louise, Niamh, and everybody at the landscape team and at the Temple Street team and Way to Go, thank you so much for adding in this perspective, which again is really important. We are really concerned for the next generation, and we're really keen to do the right things, and you're giving us incredible direction. I'd like to thank all of the panelists so far, and we have finished just 4 or 5 minutes over on what was really an absolutely packed program. And thanks very much for bearing with us and keeping to time. There is a movement break, so move, think, reflect, Do come back, okay? The second part of the program will be taken over by Dr. Jean O'Connell, and we'll bring you through. So we are looking with Carl Roberts, looking at the whole issue of hunger and what drives it. We're also looking at sleep with Dr. Erla Sveinsdottir, and also further panel conversations. So do catch up, do look at the chat. There are lots of good things in terms of websites, in terms of the link to the survey, to the Safe Food website, and all of us on panel will devote ourselves during your movement break to answering more of your questions, and do keep them coming. And maybe take time to tweet. I suppose that's a kind of movement as well. It's very important. Thank you so much.
Welcome everyone to the second session. My name is Jean O'Connell and I'm a doctor working in St Concla's Hospital Weight Management Service in Dublin. I'm also chair of the Association for the Study of Obesity in Ireland, ASOI, and ASOI is delighted to be working with the HSE, RCPI and ICPO on today's event. Thanks so much to Brendan for chairing a brilliant session earlier, really educational role plays that have given us lots to think about. If you've just joined us, the event is being recorded, so it will be accessible for you to watch back anything you've missed. The second session is going to share some information about ASOI, and we also have two fantastic speakers to share the science behind appetite and sleep and how it relates to weight and obesity. We'll finish today with a panel discussion, so please keep the questions coming via the Q&A function, and you can follow us on Twitter and socials using the hashtag overweight and obesity. I mentioned the organization ASOI earlier, and some of you may be wondering who or what is ASOI. So we're starting this session hearing a quick outline of who we are and the kind of work we do from Dr. Sarah Brown. Sarah is a registered dietitian and lecturer in clinical nutrition and dietetics at the School of Public Health, Physiotherapy and Sports Science at UCD, and she's a member of the ASOI committee. Over to you, Sarah.
Thanks, Jean. So in this short presentation, I'm going to give you a background about ASOI, who we are and what we do. So we're the Association for the Study of Obesity on the island of Ireland. ASOI is the representative body at the European Association for the Study of Obesity and the World Obesity Federation. ASOI aims to develop an understanding of obesity through the pursuit of excellence in research and education, the facilitation of contact between individuals and organisations, and the promotion of action to prevent and treat obesity across the island of Ireland. We have a major focus in advocacy to reduce obesity stigma, and more of that in our activities as I go through the presentation. At the moment, this is who we are. We're a mixture of clinicians, researchers, public health representatives, educators, patients. And the current committee is chaired by Dr. Jean O'Connell, who you've just met. Our secretary is Dr. Kathy Breen. Our treasurer is Louise Tully, who you met earlier. And our patient representatives from ICPO are Susie Burney and Maura Murphy. We have other committee members, Dr. Grace O'Malley from RCSI and CHI, Karen Gaynor, myself. We have a number of members from the Food Safety Authority of Ireland, Dr. Mary Flynn, Una Lyons, Claire O'Donovan, Caroline O'Donovan, and Niamh Arthurs from RCSI and CHI, who you also met earlier. So I'd like to give a very brief overview of the ASOI activities from the last year, just to give a flavour of what ASOI do and what we're about. So many of you, or some of you, or you may not have heard of it, but in 2020, the European Congress on for Obesity and the International Congress on Obesity was due to be held in Ireland in person in the Convention Centre, which was a huge event. Due to the COVID-19 pandemic, it was postponed from May 2020 to September, and it moved from an in-person event in Dublin to a virtual conference. It was still hugely successful, and the whole Congress was chaired by ASOI member Dr. Grace O'Malley. There was 3,631 attendees from 83 countries, almost 900 abstracts submitted, and we had sponsors in Ireland here from the Department of Health and RCSI. There was widespread media coverage, including those listed here, both nationally and internationally. And just a date for your diary, the European Congress on Obesity will return in person in Dublin in May 2023, and ASOI are involved in the organisation of that. More recently, our clinic, we are developing within ASOI clinical practice guidelines, and these are being adapted from Obesity Canada's adult obesity clinical practice guidelines. And ASOI successfully led a bid to adapt these in a pilot project, which involves ourselves in Europe and Chile in South America. So the aim is to develop high quality standards in healthcare for people living with obesity in Ireland. And it goes really nice with the model of care that's just been released in the last year. So the topics will include reducing stigma and understanding obesity as a chronic disease, the role of mental health, nutrition, activity, medications, and surgery in obesity care. And ASOI Secretary Dr. Kathy Breen is leading out this work, and it will involve a wide variety of Irish specialists who will contribute to the development of the various topics that I've just mentioned. This work is ongoing at the moment, and we would expect it to be almost complete by the end of 2021. So in 2022, look out for webinars and resources to support the implementation of the new clinical practice guidelines for Ireland. I'd like to highlight now some of our advocacy work that ASOI and ICPO do together. So in 2021, we very much led out by ICPO, the Irish Coalition for People Living with Obesity, had an advocacy campaign to mark World Obesity Day. And the ASO, which is European Association, and the European Coalition for People Living with Obesity awarded us a joint award for this advocacy campaign. So there was a range of events. There was a live webinar with patient voices and a panel of healthcare professionals. There was a very powerful video of people living with obesity, living their best lives. And there was also tips and advice videos responding to concerns from patients. And that was very much welcome in the times of lockdown and pandemic. You can actually still watch the full video and events and check out the ASOI website for links to those. And there's a couple of pictures of celebrating that award that was given. So these are a couple of headlines. We had a lot of communication and media events during this advocacy campaign. And there's a couple of headlines from some national newspapers. And that's a video from one of the webinars. We also have an education focus within ASOI, and we have a newly established working group that have current actions. The first is to develop a repository of obesity-related research happening in Ireland. And we started this process for ECO-ICO 2020, and we are going to build on that. And it's really to have a repository so that healthcare professionals, researchers, and patients can interact and see what's happening in relation to obesity-related research in Ireland. We also plan to create an education research repository to promote effective healthcare professional training at undergraduate, postgraduate, and CPD stages. And we are also currently contributing to the Obesity Stigma Education for All working group, and that's a national group. And if any healthcare professional educators are here today, we're open to new members on that group. I'd like to mention ICPO and their weekly support meetings. They hold weekly meetings online, and these are hugely important in terms of patients coming together to support each other, but also to provide information. You'll see in one of the notices here that specialist physiotherapist Colin Dunleavy joined the group to give information on physical activity for people living with obesity. And it can be a really, really excellent way for patients to reach out and find support in each other and information as well. So you can look them up on Facebook, Twitter, or email icpobesity@gmail.com. We are very active in terms of communications and media between ASOI and ICPO, and most notably the patient voice features much more frequently in the last few years, which we see as hugely positive. ASOI and ICPO rank high in simpler results from campaigns and conferences, and we have a really small but very active social media team. These are some of the communications and media we have been involved with in 2021. And you can see that almost on a monthly basis, there is some national or European contributions in terms of raising awareness around obesity, and also reaching out to patients, people living with obesity as well. And particularly in March, you can see all of the communications that happened around World Obesity Day. And these are some of our results from, tweet events and on exposures on Twitter. So in our ECO conference, we were on the 10 top influential tweeters, the same in our Living with Obesity campaign in 2020, in the top 10 influential tweeters, and in ECO-ICO 2020, which was the European and International Congress, we were very prolific tweeters at those times as well. So all of this has really helped to put the messages around obesity, particularly in relation to the patient voice, at the centre, and highlight the work that's going on there. So in conclusion, I'd like to encourage anyone interested, that would include healthcare professionals, students and the public, to join ASOI. And you can see there's a members area on our website. You can see the full benefits of becoming an ASOI member. And there are different levels of cost involved depending on whether you represent healthcare professionals, students and the public. And I'd encourage everyone to take a look at our website. And thank you very much.
Thanks, Sarah. And we have some ASOI members on the panel at the end of this session. So if you would like to ask any questions about ASOI activities, please ask those or any other questions using the Q&A option at the bottom of your screen. So we're now going to hear from Dr. Carl Roberts. Carl is a lecturer in psychology at the University of Liverpool. His research focuses on psychobiology of behaviors and brain imaging of reward and behavior control. Just before Carl's talk, you'll also hear some brief words from ICPO advocate Diane, sharing her personal experience.
Hiya, Diane. It's good to see you. Diane, we'll get straight in. Can you give us a brief introduction of yourself?
Yes, hi Susie, good to be here. My name is Diane Charlton and I'm here in the West today. I am a committee member with ICPO and I'm also a patient with the Galway Weight Management Service.
Thanks, Diane. Diane, today we're going to chat a little bit about hunger, and would you share with us some of your experiences?
Yes, well, I guess, you know, when I think about hunger, if I skip my breakfast, for example, in the morning, it'll certainly catch up with me later on in the day. And then, you know, I reach for foods that wouldn't be as nutritionally sound as I would like. And also stress is a major trigger for my hunger. When I'm stressed, I often feel hungry.
Thanks, Diane, for sharing that. Diane, would you have had direct treatment for this?
Yes, absolutely. With the Galway Weight Management Service and the psychology part of it, I attended compassion focused therapy. So I found that very, very beneficial and have, you know, learned a lot from it. And the one major thing that I took from it is to differentiate between my physical hunger and my emotional hunger. And I learned that when I'm feeling hungry, physical hunger is felt from the neck down, and then emotional hunger is felt from the neck up. So I've really used this to help me manage my hunger.
That's great, Diane. Thank you. Diane, on a day-to-day basis, what would you say are your coping strategies?
On a day-to-day basis, I must have an eating plan. And I plan my meals in advance, a day in advance, and then I would keep a diary, or very often I would take a picture of what I eat just to keep a record. Shopping is very important, to have the right foods in and have a shopping list, and also to keep well hydrated with water during the day. And I guess lastly, managing my emotional hunger would be to be very aware of my stress triggers, and when I'm stressed, to maybe just to engage in a little bit of self-care and just be very aware.
Diane, that's absolutely great, and we're looking forward to hearing now more about the science of hunger, which will hopefully raise more awareness too, that it's not so straightforward. We really appreciate you sharing your experiences today. Thank you.
No problem. Thanks very much, Susie. Thanks all.
Yes, hello, thank you. So yeah, I'm Dr. Carl Roberts. Lecturer in psychology here at the University of Liverpool. So I'm presenting to you today from my office in Liverpool University. It's a pleasure to be here with the ICPO for this webinar. My talk is entitled Body Weight is Not a Choice, Understanding the Drivers of Appetite, Our Brain's Biology and Behavior. So let's get started. So an overview, I'm going to cover hunger and satiety signaling from our gut to our brain, neurobiology of reward. People living with obesity have a biological vulnerability for weight gain, and I'm going to talk about how dieting intensifies this biological vulnerability, making behavior change incredibly difficult. I'm going to touch upon the broader psychology of weight gain and things that are associated with weight gain, such as depression and stress. And ultimately, all of these things should help us to further understand obesity as a disease. Couple of disclosures. I have grant support from Unilever, and I do consultancy with a pharmaceutical company, Boehringer Ingelheim. All right, so first a couple of slides about appetite expression. So human eating is an incredibly complex and varied behavior, and the variation and complexity is enormous. And our eating behavior is driven by complex biological signals from our gut and our brains that result in feelings and experiences. These feelings and experiences, such as I feel hungry or that food looks nice, are things that we all understand as psychological experiences that are the result of complex biological signaling. So hunger, satiation and satiety largely relate to signals from peripheral physiological signals. These are signals which are sent to areas of the hypothalamus in the brain through the vagus nerve to signal the presence or absence of nutrients in the gut. So the brain integrates numerous signals from the body in order to determine the energy requirement of the body and to modify our experience of hunger and initiate the relevant behavioral actions in response to this. So we feel hungry, we eat. And we've started to understand the biology that underpins these short-term feelings of hunger. Before I go on to the next slides, I want to be clear that well, it's obvious now that eating behavior is hugely more complicated than simply responding to short-term hunger signals that are sent from the gut to the brain. However, I want to outline how these signals work before we move on to more reward and then craving-driven neurobiology and the broader psychology of weight gain. So first of all, when we talk about gut body signaling to the brain, we're generally talking about signals that lead to psychological experiences of hunger, satiation, and satiety. Now, these are things that we're all familiar with, but these are just the terms that we use in the psychology literature. We all know what hunger is, so you know, the drive to consume, the feeling of hunger. Satiation is the process within a meal that generates this kind of feeling of feeling full, and satiety is the end state of feeling full between meals, basically. Okay. So what are the signals that generate these feelings? In brief, there are important biological mediators that help regulate appetite in the short term, and these are satiety-related hormones. So after we eat, signals are generated by nutrients in the gastrointestinal tract. So hormones are released from the stomach, the intestine, and the colon. And these hormones, which are satiety-related peptides, signal to the brain, and this specifically, they go to the hypothalamus in the brain, which coordinates these kind of feelings of hunger, and some signals exert their effects during the meal, which is why we start to become full during a meal, and some others after a meal, which is why we maintain feeling fullness between meals. Some signals are stimulatory, so the signals, if you ever hear of things like ghrelin, this is a stimulatory signal, and this makes us feel hungry, but most are inhibitory, so things like you might hear of CCK and GLP-1. These are basically satiety related peptides that make us feel satiated and make us feel satiety. Okay, so these short-term signals that are released in response to foods are also modulated by long-term signals that act in a constant tonic fashion. So two important long-term signals are insulin and leptin. So you might be familiar with these. So insulin secreted by the pancreas and leptin secreted by adipocytes. So these are signals that inhibit neurons that promote energy intake and excite neurons that reduce energy intake in the brain. So these signals basically, insulin and leptin modulate how responsive the brain is to the satiety signals that I spoke about on the previous slide. So these long-term signals change in relation to weight gain. So as we gain weight, these reduce the short-term satiety signals to the brain. So taken together, all of this means that there's a complex biology that belies our experience of hunger. So our understanding of these short and long-term peripheral biological signals comprise the traditional perspective of energy homeostasis in response to the body's energy needs. However, physiological models of food intake give relatively little attention to psychological influences, such as the enjoyment and pleasure of eating, which can be termed food hedonics. So hedonic eating, whilst there is an impressive gut-brain system designed to achieve energy homeostasis, given the prevalence of people living with obesity, it's clear that these signals are unable to prevent weight gain in a modern obesogenic environment. Palatability and pleasure are arguably the most powerful motivators of food intake, and the rewarding nature of food easily overrides any homeostatic control of appetite, and this is why food reward drives eating in the absence of hunger. So basically, we've evolved efficient motivational mechanisms that drive us towards food, encourage overconsumption, and permit storage of excess energy as protection against food shortage as well. These would have been evolutionarily beneficial, these really efficient motivational systems that we have. The prevalence of people living with obesity is an indication of the efficiency of these hedonic processes in governing eating motivation. Arguably, weight gain is a natural response to our changing food environment. So in terms of what the concepts that we use in the psychology literature and our psychological experiences, we use the terms wanting and liking. So these are separable components of reward. We have wanting, which is the motivation to consume a specific food, and these manifests explicitly in things like cravings for foods, or implicitly like incentive salience, so the ability for foods to grab our attention, the sight and the smell of foods to grab our attention, to grab our attention. And it's food advertising and things like this that work on this incentive salience, this wanting aspect of our kind of reward system. We have liking as well, which is the actual sensory pleasure elicited from eating, so the actual pleasure that we get from eating. So if we see that wanting is our drive to eat, and can result in things like cravings and making things more appeal to us more in our environment, whereas liking is actually the pleasure that we get from eating. So neurobiology of desire. So basically, all this slide is to say is that there's a complex neurobiology and neurochemistry which underscores these hedonic wanting and liking aspects of eating. For example, the opioid and the cannabinoid neurotransmitter systems are heavily involved in wanting and liking. So these are just examples of a couple of neurotransmitter systems which are directly involved in wanting and liking of foods. In some people, these systems may be more active than others, and so the motivation to eat is stronger in some people. And once we start eating, that episode of eating is maintained by how much pleasure we are getting from eating that food. So to exert control or resist foods requires constant conscious control over incredibly powerful forces that drive us to eat. So this is the energy balance equation diagram, which is something that you might all be familiar with. And whilst it's true that behavior has a critical role in the etiology of weight gain, contributing to both excess energy intake and inadequate energy expenditure, one thing that the eat less, move more mantra fails to capture is how difficult behavior change is to achieve. So due to weak satiety signaling from the gut or powerful hedonic processes, behavior change is incredibly difficult, not only because individuals with obesity have a biological vulnerability driving their behavior, but also that patterns of eating and activity are shaped by lifelong learning. And behavior modification must also tackle entrenched habits as well. Secondly, even if change is achieved, maintaining healthier behaviors in an environment that promotes weight gain demands constant exertion. The obesogenic environment primes an individual to relapse into their pre-interventional behavioral repertoire. And also problematically, appetite regulation is asymmetrical in that the body defends against underconsumption irrespective of current weight status or energy reserves. So I'll touch upon these things more in the next few slides, but basically weight management will only work if we take a personalized approach to treatment. And given all these various biological factors, clearly clinical response to any weight management program will vary greatly. Thus treatment requires tailoring to individual specific needs. So just as an interim summary, eating behavior is influenced by the regulatory and hedonic components of appetite. The former is driven by signals generated by ingestion, and the latter by palatability of foods and the wider food environment. The concept of energy balance fails to capture the difficulty of lasting behavior change, especially in an obesogenic environment. Okay, so there are many different eating behaviors that have been identified that are associated with weight gain, and these are all underpinned by our biology and our neurobiology. So as we've said, individuals with obesity have a biological vulnerability for weight gain, which is manifested in eating behaviors that lead to overconsumption. So we see that individuals living with obesity tend to demonstrate weaker satiety during a meal. So during a meal, people have weaker satiety signaling. That signaling is not working as well for some people as other people, and so they don't feel the same process of becoming full during a meal. And also individuals with obesity that have demonstrated weakened satiety signals after a meal, so they feel hungrier quicker. Moreover, appetite regulation is more likely to be overwhelmed by environmental cues to overconsume, because people with obesity have been shown to show greater responsiveness to food cues, the sight and smell of foods, heightened hedonic responses to palatable foods, and experiences of uncontrolled hunger and greater disinhibition of eating behavior. So we have these different behaviors that are associated with adiposity, but they're all underpinned by our biology, our neurobiology. So this looks like an incredibly complex diagram, but this is basically just to show that appetite regulation involves a complex interplay between satiety, reward, and inhibitory control. So if you understand that under normal conditions, individuals living with obesity may experience weaker satiety signaling or greater reward responding, it makes sense that these things would be working constantly to undermine what us psychologists call inhibitory control or behavioral control. So if we understand that some individuals living with obesity have weakened biological regulation of hunger and satiety and are also highly responsive to food cues and hedonics, then exerting that behavioral control that we just saw in the last slide to reduce calorie intake already requires constant exertion anyway. Then we add into the mix the food environment with all of these factors here. Then we see it becomes incredibly difficult to modify behavior in the face of constant food cues. So we as scientists, the food industry and the government really need to start working together to improve the wider food environment. Now I want to just briefly touch on dieting and energy restrictions. So on top of the biological vulnerability already associated with individuals living with obesity, which make behavior change incredibly difficult, dieting and energy restriction intensifies all of these things. So when we diet, we become more obsessed with food. We have increased response to food cues, increased cravings, loss of concentration, dysphoric mood, and all these contribute to the failure in dieting. Energy restriction and weight loss reduce satiety hormone levels, and this might even outlast the diet. So then hunger is a barrier to and also a consequence of dieting. When we diet, we get increasingly preoccupied with food. We have relentless thoughts of food, and eating inhibits concentration on usual daily activities. And we have serious difficulties adhering with a diet when confronted with unlimited access to foods. When we diet during and after weight loss, we see changes in these in our satiety signaling. So after weight reduction, the brain is stimulated to increase calorie intake by changes in levels of circulating hormones. So, we see leptin and GLP-1 go down and ghrelin goes up. So this increases appetite, and we have increased preference for energy dense foods. So all of these things are working against us to defend against us, sticking to a diet and reducing our calorie intake. In addition to those peripheral signals, we also have changes in our food cue reactivity and cravings. Hunger heightens the perceptions of foods in our environment. Dieters experience stronger cravings that are harder to resist, and typically for foods that are being restricted. So basically food cue reactivity and cravings also act as barriers to weight loss success. So dieting is difficult. Dieting increases hunger and food cue responsiveness, undermining ability to resist cravings and resist tempting foods, and in turn, the ability to cope and maintain the diet. Dieting has negative effects on mood as well, which reduces self-regulation of controlling behavior and reintroduces food-related coping strategies. Negative mood reduces inhibitory control, our ability to resist, producing a cycle whereby ability to control behavior and self-regulation is undermined. So an interim summary here. Individuals living with obesity tend to demonstrate weaker satiety signaling and increased responsiveness to the food environment. This will weaken inhibitory control and undermine our ability to resist. Dieting also tends to weaken satiety and increase responsiveness to foods, irrespective of weight status. So individuals living with obesity have a biological vulnerability, which is intensified by dieting, that makes long-lasting behavior change very, very difficult. Individual weight management plans require patient input to tailor interventions to individual needs. So above and beyond the brain and biological drivers which relate to hunger and hedonics, there's also the broader psychology of weight gain to consider. Things like life events, stress, coping, and depression. So depression, we saw in the case study that Emily reported feelings of depression, anxiety, stress, and low self-esteem. And there are systematic reviews and meta-analyses on the longitudinal relationship between depression, overweight and obesity, which suggests that baseline depression increases the odds for developing obesity. Also, living with obesity also increases the odds of developing depression. So low mood states can seriously undermine a diet because self-efficacy and the motivation have gone. So the conclusion here is that there is a reciprocal link between depression and obesity, and therefore it's no surprise that we saw depression as coming out in that case study where Emily reported feelings of depression. Personal circumstance also plays a role in weight gain, as well as mental health issues. So things like current events, so traumatic life events such as relationship breakups or widowhood or other forms of loss can affect body weight. Past trauma as well, so serious and sustained abuse and neglect may undermine self-care behavior in adulthood. So stress, mood, and weight management. The effects of stress and mood on dietary restraint and weight management success are widely acknowledged. So Diane in her video acknowledged stress as a trigger, and stress is mentioned in Emily's case study as well. Repeated exposure to stressful life situations are associated with greater preference for energy-dense foods and nutrient-dense foods rich in sugar and fat. And coping is the mediator here. So if your coping strategy has always been eating, then you're under stress. So when you're under stress, you're more likely to go into your learned coping strategy. So stress management and appropriate coping mechanisms are critical for development here. So this slide is just to say that the temptation to eat is constant and is magnified when we're under stress, and we need to manage and management of temptation requires constant exertion. So we need to reduce exposure to temptations, prevent them triggering lapses, and when they do trigger a lapse, manage the consequences of these lapses. So in summary, appetite consists of interactive processes of hunger, wanting, liking, satiation, and satiety, which all impact on inhibitory control. People living with obesity have a biological vulnerability for weight gain, weakened satiety signaling, and intensified reward signaling. Dieting and energy restriction intensifies biological vulnerabilities and further compromises appetite control. It only takes a momentary lapse in otherwise constant exertion to undermine a diet. In terms of the broader psychology, stress and coping style mediate the link between depression and BMI through temptations and lapses. We need to develop better coping mechanisms. For example, Diane mentioned compassion-focused therapy and distinguishing between physical and emotional hunger. She also mentioned being aware of stress triggers and engaging in self-care. Interventions targeting reward, satiety, inhibitory control, and personal psychological triggers, for example, stress and mood, could provide personalized approaches to weight management, allowing patients to gain perceived control and self-efficacy, which are important for long-term success. So thank you for listening. Just wanted to reiterate that obesity is a chronic relapsing disease and not a choice. And we need to reduce stigma. We need to use less stigmatizing language around this. I also wanted to thank ICPO for inviting me to talk here today. I think that they're a really, really great community, and it's great that you have this coalition of people where you can share your experiences, and I think it's a great thing to keep talking. I'll be around on the panel for any questions, but if you want to get in touch with me directly, then feel free to email me or get me on Twitter as well. Thank you very much for your time.
Thanks very much to Carl and Diane. Carl, as he said, will be on the panel. So if you have any questions now following his talk, please use the Q&A function at the end of your screen. And a quick reminder again that you can follow us on Twitter and socials using the hashtag overweight and obesity. We're now going to hear from Dr. Erla Svensdotter. Erla's a GP and obesity specialist in Iceland. She has a master's degree in public health and has worked in several specialist multidisciplinary obesity centres in Iceland. And just before Erla's talk, you will also hear some brief words from ICPO advocates Mike and Claire sharing their lived experience of obesity.
Hiya, Mike. How's it going? Do you want to give us a quick introduction?
I will indeed, Susie. My name is Mike. I'm from Limerick. I've been attending Loughlinstown since 2007. I've had surgery, and to this day, I still struggle badly with my weight.
Yeah, thanks, Mike. Can you tell us a little bit about your sleep apnea and how it came about, you found out about it?
Yeah, in 2004, I was diagnosed with sleep apnea, not by my doctor, but myself, and basically went to the hospital, done the sleep test, had the sleep apnea, and I've been on the machine ever since.
And can you tell me what were the signs that made you think you had a problem with your sleep?
Basically waking up 2 or 3 times a night, gasping for air.
Sure, that must have been frightening.
Very, very frightening, yeah.
How long have you been using the machine now? Did you have any trouble at the start getting used to it?
17 years now I'm on it since August, and yes, for the first 3 or 4 months it was absolutely horrific because I'd be very claustrophobic, and basically I would be taking the mask off a couple of times a night, but now I wouldn't be able to sleep without it.
Sure. And so have you seen a huge improvement in how you are during the day from having a better sleep? Like, did the machine really make that difference to you that you noticed it?
Yeah, definitely. I mean, you know, your energy levels during the day while you're on the machine is absolutely second to none. You know, you just have a lot more energy. You can do a lot more things. Before I was diagnosed, I thought I had a full night's sleep, but I didn't. And basically I was during the day falling asleep 3 or 4 times a day, once or twice even behind the wheel of a car, which was very scary.
Oh, word. And so from that, Mike, do you think that affected possibly your weight management plan, like how you would maybe choose food or what exercise you could do?
Definitely. I mean, you wouldn't have the energy to get up and cook a proper dinner. So basically a lot of takeaways, a lot of, you know, fast food. Exercise was very, very limited because you just didn't have the energy. So, you know, it makes a big impact on your life when you are diagnosed with it and you do get the right treatment.
Sure. And it's great to hear that it had such a positive improvement for you.
Oh, definitely. Yeah. I mean, like I get up now in the mornings and, you know, you have your 8 or 9 hours sleep and not interrupted. You know, you can check your machine the following morning just to make sure like that everything was okay, and tells you the amount of apnea attacks you've had and the severity of them. So, you know, it really is. It's made a massive difference to my life.
Fantastic. Just one last thing, Mike. Now, do you see like any need for you to come off the machine now since you've lost weight after having surgery, or would you continue to use it?
Well, going by my stats in the morning when I check it, I still would get apnea attacks during the night. But to be honest, I'd find it very difficult to sleep without it now. Sure. I've had 1 or 2 episodes like where I've, you know, in emergencies where I've had to go somewhere and stay the night, and basically, you know, I just couldn't sleep. You know, I would not be able to sleep without it. There's no doubt about it.
Mike, we really, really appreciate you sharing your experience with us today. Thanks a million.
Thanks, Susie.
Hiya, Claire. How are you? Do you want to give us a quick introduction?
Yeah, I'm Claire. I'm from Tipperary. I've struggled with my weight all my life. I'm currently attending Galway waiting bariatric surgery.
Thanks, Claire. Claire, very quickly, we'll get straight into it. Have you problems with your sleep, Claire?
I do. I have problems with my sleep since I'm around 9 years old, and it has been very, very bad. So just suffering with it ongoing. It's a daily thing for me.
And would it be insomnia? Like, have you spoken with the GP?
I have chronic insomnia, and then I get like nightmares when I do sleep, and night terrors and stuff like that.
That's terrible. And can I ask, do you think that has had an effect on your weight, or how you make decisions each day when you're feeling tired from the lack of sleep?
Yeah, it has had a huge effect on my mental and physical health. And then it was only in recent years I realized it was having an effect on my weight, because some days you don't know what to eat. You might eat something, you could eat in the middle of the night when you're not supposed to be eating at all because you're awake all night.
Sure.
So it definitely has affected my weight, yeah.
Do you think it'd be helpful, Claire, just before we finish up, that GPs and the weight management might know that it's good to discuss sleep problems as part of weight management?
Yeah, I think it would be very helpful, and just for people to know a little bit more about sleep problems. It's very hard to get any help with it, so it would be very helpful. And then if people had more awareness that it does affect your weight, that would be really good.
And they might stop blaming themselves. Claire, you're a star. Thank you for hopping on for us. Thank you.
Thank you.
Hi. Thank you so much for inviting me to be with you. It's been a wonderful day. What I'm going to talk about is sleep, and what I'm hoping to is to get you curious to learn more about sleep and how important it is. I'm just going to share my slides with you. Do you see the slides? So what I will start by doing is talk about normal sleep, then sleep relation to health and weight gain, and finally, what can we do about it? Sleep is not just about rest. It's a very active process, actually, and very important for our normal body function. There's a lot of metabolic things going on. There's a lot of going on in the brain, in memory and learning. We are repairing cells and tissues, and most of the memory and repairing of the cells is happening in our deep sleep. But we are also strengthening our immune system, and there's so much going on in our body while we are sleeping. I sometimes look at it as we are giving the floor to the cleaning crew and the repairing crew so that they can do what needs to be done. In order to fall asleep and to stay asleep, we have a lot of complex biology going on in our body. There are so many things that need to add up in order for us to get a good night's sleep. But thankfully, don't have to worry about it because our circadian clock is taking care of balancing all those things together. And for example, melatonin, the hormone, goes up in the night and down again in the morning. And the opposite thing goes for cortisol. We have a product called adenosine that builds up in our central nervous system that makes us sleepy. Our body temperature goes down, our heartbeat and blood pressure goes down, and a lot of things are organized by our circadian clock so that we can fall asleep. We go through 4 different stages of sleep every night, and we go through some few circles every night. Every stage is important and different, both in function and biology. And to make a very, very simplified picture of our sleep for one night, I'm showing you this graph. The blue area is when we are falling asleep. We go through the first and then second stage down to our deep sleep. The blue area is really a deep relaxation and is not supposed to take more than a few minutes. If it lasts more than 30 minutes, it's a sign of insomnia. And usually we go to the deep sleep and the repairing of the cells and all the organizing things in our brain for learning and memory and all that happens, and we take another dive, and then we have finished that chapter. Then we go to the dreaming sleep and to rest our body, which is important as well. But if we shorten our sleep, our body makes sure that the most important things are already done. So just imagine how wonderful design our body is. So we always, even though we get only a few hours sleep, we always get to do the most important work. Then we go through a few cycles, and it is possible to wake up in every cycle and go all the way up to the wake state. And that is quite all right. And we can get a perfectly good sleep even though we wake up a few times during the night. However, we are not supposed to stay awake many times during the night. Then that is a sign of insomnia. But I can tell you, I was very relieved when I found out that it was normal to wake up a few times during the night, because I tend to get stressed if I woke up and, I had a lot of things to do next day, and I, had to get my sleep. And the only thing I did was activate my stress system and make sure that good night's sleep was not possible. So just knowing that and be able, just go back to sleep, and this is all normal and okay. That helped me out, at least. For how long should we sleep? 7 or 8 hours is very good. Some people only need 6 hours, some need 9 hours. But as with almost everything in our body, too little is not good, but too much is not good either. Because we have seen that, for example, the inflammation levels, they get higher when you sleep too little, and also if you sleep too much. So there is this average line somewhere we need to find for ourselves. Even though sleep is very important, it's not dangerous to lose night's sleep every now and then. The only thing that can be dangerous to our health is that we are more likely to have an accident when we have a bad night's sleep, but so we need to be extra careful. But we are more likely to get emotional, and it's difficult to concentrate, and we are less likely to exercise, and we feel more hunger, and we are more likely to have unhealthy meals. As Carl explained, how this affects our hunger. And that is a brain response, not something that is connected to willpower or anything like that. But if we have a poor sleep night after night, week after week, month after month, something starts to not go as well as it should be. So we are in more danger for all kinds of heart diseases, diabetes, obesity. There's a low-grade inflammation, which then again can lead to a lot of other diseases. Our immune system does not function as it should, and all kinds of things that can happen to our health. So if we have a long-term bad sleep. And this can also be the other way around, because there are many diseases that can affect our sleep. For example, chronic pain, asthma, stress, and that can disrupt our sleep. So always when we are trying to find out what is it that makes my sleep bad, we always have to look at our health overall. And also there we have special sleep diseases, obstructive sleep apnea and chronic insomnia being the two most common ones. And we have already heard stories about how it is to live with those diseases, and I'll explain a little more. Insomnia, then we have difficulty falling asleep, and we have interrupted sleep. We wake up early and we have a poor quality of sleep. This can be okay, and our body can find out what to do about that and make everything fall into place again. But if it lasts for more than 3 months, it's chronic insomnia, and that starts to affect our health. And as for Claire's story that she was telling about her nightmares as well, which might be a sign of a rare sleep disease, and there are a lot of them, and nightmares is one of them. And that is a special condition that needs to be checked special through measurement and referral to a sleep specialist. And we have to remember that we can sometimes have more than one problem at the time. And sometimes we can both have sleep apnea and insomnia, and that does not make our life very easy. But obstructive sleep apnea, and we heard that Mike told us about how it is to live with an untreated sleep apnea. That is not a quality of life. There's nothing really that awakes our stress response as much as not being able to breathe, which is exactly what happens in sleep, obstructive sleep apnea, when our airway closes when we fall asleep. Usually we see snoring and grasping for air and daytime sleepiness, but the symptoms can be much more moderate than that. It can be constant headache, difficulty to concentrate, frequent urination during the night, high blood pressure. And the rate of sleep apnea is much higher in people living with obesity. And we know that sometimes sleep apnea gets better when people lose weight. And we often hear that people, especially with mild sleep apnea and obesity, they're just advised to lose weight, and then probably the sleep apnea will get better. But it's very, very difficult to lose weight when we have untreated sleep apnea. Because the stressful situation going on in our body the whole night after night, it makes it very difficult, almost impossible to lose weight. So we should have a very low threshold to measure if there is sleep apnea and treat it, and always treat the sleep apnea first, then a person is able to lose weight. And if the sleep apnea goes away, that's very good. If the treatment needs to go on, that's very good as well. But we have to do this in this order. Treat the sleep apnea first. But the most common thing for a bad sleep is just bad sleep hygiene and the environmental disturbances. And there we have to take a look at what is it that we can do ourselves. And I'll just come to that later. But it's really, it doesn't matter for the body what is interrupting our sleep, because the answer is always the same. We have a very strong stress response, and it just happens. Our system is not asking us for permission to rise this stress response, and the whole body is prepared for fight. And in that condition, sleep biology is not happening. All the things that we need to take place in our body in order to get a good sleep, the blood pressure going down, the heartbeat slowing down, thermal regulation is disrupted, and that again affects a lot of hormonal systems, and the chain goes on. The body with a full stress response going on while we are trying to sleep, it reminds me of when we are in our car, putting the pedal down, but the engine goes wildly, but we forgot that our car is still in park mode, so that we make a lot of noise, but we don't go anywhere. I hope that someone else is familiar to the situation, that I'm not the only lousy driver in this group. But that is what is going on in the body. All the system is on full swing, but we don't go anywhere. To take this a little further, we, for a long time, sleep disorder or short sleep time or bad sleep quality rises our hypothalamic pituitary adrenal axis. And that leads to a chain of action in our biology. Our cortisol goes up, and we get insulin resistant. Adenoprolactin, which is a product from our fat tissue, goes down, and ghrelin, that makes us hungry, goes up, and leptin, that makes us feel full, goes down, goes away. And I will explain that a little bit more on the next slide. But that means we get more hunger. If we gain weight, we are more prone to get diabetes or obesity, and we are in danger for a metabolic syndrome. But there are so much other things that can make this hypothalamic pituitary adrenal axis rise. All kind of stressful events that is going on for a long time. And for example, childhood trauma, whether it is neglection or some event. If you are living in a constant stressful situation, you never get time to rest. Like Emily with 3 children, a lot of conditions going on in her body and mind, and her husband being away for a long time, and that does not help the biology for a good night's sleep or a good weight management. So what happens there is not something that is connected to willpower or personality. So a little bit more about sleep and weight. When we don't get enough sleep, our ghrelin goes up, as I already mentioned, and cortisol leads to accumulation of energy in our visceral fat. Visceral fat is not good for our heart and other internal organs, and visceral fat disturbs adiponectin, which in its normal function is produced by the fat tissue, and it contributes in relaxing our sympathetic system and calming our inflammatory response. For those of you who thought that our fat tissue was only doing something bad, it's a very necessary tissue and can do very good things as well. And if we sleep badly for a long time, we get insulin resistant, and we are more prone to put our energy in our fat tissue. And we all know what that leads to in our daily life. This brain that is under this kind of pressure is not asking for spinach or broccoli. Energy dense food is what we need. And I would like to mention a little bit further about what activates our stress system, which can be a lot of things. And one thing that is a stress situation going on for a long time, which is the weight stigma. And that has an enormous effect on our biology. If we are always doing something wrong, either it's according to our inner voice or the society, we always have the wrong diet on the wrong time, we don't like our body, it's supposed to be some looking differently, we feel shame, we try to seek help, and we're always told to eat less and exercise more, and we start to starve our body and not take good care of it. So for weight management, as well as to improve sleep quality, positive self-talk, self-care, body acceptance and respect is very important. And that is something we can start doing right now. Some more tips for a healthy sleep. We know that caffeine in the afternoon is not a good idea. Heavy meals before sleep can have a bad influence in our sleep, and the blue light from screens, we should avoid that for at least 1 or 2 hours before going to sleep. Alcohol and smoking are never a very good idea for our health, and that interrupts our sleep as well. What we should be doing is to make a good routine in our daily life, to get up at the same time, go to bed at similar time, make sure that our bed is comfortable, our bedroom's comfortable, and practice some relaxing routine. I know I sound boring, but this really has a huge effect on our sleep. What we really are doing is that we are helping our circadian clock to keep everything in balance. And light has a huge effect on our clock. And for example, if our clock knows that according to the circadian rhythm, melatonin is supposed to be produced now, and its level to go up. But we have a constant daylight, which is our blue screen. Our circadian clock gets confused. What am I going to do now? And maybe that disrupts the normal sleep biology. Meal timing, exercise, and bed routine, all those things are giving our clock signs of what to do at each time. Some of us have a circadian clock what doesn't bother what we do, it just works, and our life can be quite easy. But for most of us, we have a circadian clock always trying to read what is going on in our lives and adjust us to it, because our body is amazing on how it can adjust us to different situations. So what more can we do to improve our sleep? Always start by doing what can I do myself to both for my health and for the environment. What can I do to improve my sleep? Then seek help to treat underlying causes that might disrupt the sleep. We should have a low threshold to measure sleep and absolutely treat obstructive sleep apnea. And with people living with obesity, even the mild one. And we can seek cognitive behavioral therapy if we are having insomnia. And we should relax on a regular basis. There are a lot of different methods possible, and it's very important to find our own. Trust me, this needs practice. It doesn't work if you do it only once or twice. Practice, 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 and then it starts working. You can use this your relax routine anywhere. Whether it's difficult to fall asleep, but you wake up too early, or you wake up in the middle of the night, you get in a stressful situation in your daily life, that's really something that is a very good thing to do. Or we could use sleep medication. A good sleep medication is supposed to shorten the time we fall asleep and make our sleep very good and improve our sleep quality. It's not supposed to have side effects or effects the day after, and there should be no addiction hazard. To cut a long story short, there is no such thing as a very good sleep medication, so we should not rely on that. But of course, we can use different kinds of medications to help us on track. And we should use sleep medication for as short time as possible, for only a short period of time. And it should be re-evaluated regularly and only used when needed, not routinely, and always in the smallest possible dose. And then we should also have in mind that a lot of the medication that can improve sleep also make our body prone to weight gain. So we have to use these medication with caution and choose the right ones for the right person. So what I'm hoping that I have convinced you that sleep is very important for our health, and that we should make that a priority in our daily life. So maybe another Netflix chapter is not a good idea. We should go to bed instead. Then when we have done everything we can ourselves to improve our sleep, we should seek help. Thank you very much.
Thanks very much to Orla and to Mike and Claire. So we're actually running a little bit ahead of time. So we have plenty of time for our panel discussion. So there's still time to put questions in the Q&A button if you have any questions following those talks. Before we go to the panel discussion, we'd like to share the second poll, which is the same poll that you're going to see a second time, and see how it compares to the poll from earlier today. So we're showing you the two questions again. Do you feel it difficult to discuss overweight and obesity? Do you believe obesity is a disease? And you can choose to go with the same answer as before, or you may feel you'd like to give a different answer. So as you have a couple of moments to fill in the poll, perhaps we could get our panel lineup ready. So our panel includes the two speakers you've just heard from, Carl Roberts and Orla Svensdotter. And we also have familiar faces from the previous session today. We have Susie Burney, patient advocate with ICPO, ECPO, and ASOI. Louise Tully, researcher in child and adolescent obesity in the Royal College of Surgeons. Niamh Arthurs, registered dietitian and researcher with Way to Go at Children's Health Ireland, Temple Street. And Donal O'Shea, endocrinologist and HSE National Clinical Lead for Obesity. So I'm wondering, can I change my view to a gallery? Oh, yes, there, that's better. And does anybody have access to the poll results? So Okay, I think that maybe probably everybody can see it there. So we've, do you feel it difficult to discuss overweight and obesity has gone from 61% to 39%? And do you believe obesity as a disease has changed slightly?
That was at 82% and it's gone up to 93%.
Ah, right, yes.
That's.
You have the previous results. Any comments on that, Donal, if I go to you first?
Well, given that behavior change or opinion change is what we're after, if you saw a 1% swing, you would be delighted, because and we knew at the start it was an audience with an interest in the condition of obesity. So to see a swing, I would say, of that magnitude is actually very gratifying. I would have thought both would have stayed the same with the kind of audience we had. So I'm delighted with that. But it's been a stunning afternoon and evening. It's getting dark now, but you know, it's been an amazing afternoon, and to see that opinion change then just at the end of it, that kind of the cherry on the cake, really.
Brilliant. Okay, well, so I should just say at the start, this is a fairly high-tech virtual event, but I have a very lo-fi solution to this Q&A, which is I have loads of scraps of paper here with some of the questions written down. So if you see me looking down, that's what I'm looking at. There's so many questions have come in throughout the two sessions, and I thought maybe we try and group them into themes so that we could try and answer as many questions as possible and get views from as many panelists as possible on the different themes. So the first theme I thought we'd go to is training, because I suppose after the role plays that we saw earlier in the day, I think we'd all agree that training for healthcare professionals is just so important. And I thought I might come to you first, Niamh, because you presented to us a really exciting project of training in the area of childhood obesity treatment. And I wondered if you could maybe outline a little bit more around the feedback that you received from the healthcare professionals about what they needed, and if maybe their confidence in treating obesity increased following the program, and also just a little bit around the nature of it, because I think some people were asking us, is it all about food, or is it more holistic than that?
Thank you very much, Jean, and thank you for the interest in the training programs. That's part of the Sláintecare Childhood Obesity Project. And if I just clarify first, there is a mandatory core module that we recommend everyone to do. The feedback from some professionals have been that they found the core module perhaps more basic, but that the advanced modules are a lot more detailed and they go into specific areas such as sleep, which you've just heard a lot from Dr. Urla, nutrition, physical activity, orthopedics and musculoskeletal. Goodness, it's late in the day. So we do have various specific topics and a lot more detail in the advanced modules for healthcare professionals. And I would really recommend that if you have registered already, that you come and complete the program, because we are at the moment, we know we've got funding until the end of October, and we're hoping that it will be extended, but just maybe complete before 31st of October, just in case. And we do know under the model of care, if I could just mention that there is a commitment in the new model of care presented earlier on by Professor Donal O'Shea to the training and education of healthcare professionals. And it has been something that's been voiced throughout the various videos that have a lot of work went into, that healthcare professionals, they don't often mean to harm or to use language that's harming or hurtful, but it is just about that education and awareness that's really needed. And a lot of our professionals would have communicated in their surveys and in our assessment of their training needs. They demonstrated that they do need more communication and training on how to communicate about weight and obesity. So it's just to say that language does matter, and healthcare professionals by their nature, we are healthcare professionals. We do really care for our patients and our service users. It's not that we mean that any of us mean to harm or heal.
Thanks, Niamh. I was thinking I might come to Arla next, if that's okay, because I'm really interested if, you know, we've identified a big deficit for training in Ireland, which Niamh's program is trying to address. Are we alone in that, or is your experience that that's potentially also a problem in Iceland or other areas?
Yeah, it's a huge problem. I think you are probably ahead of us. So
we don't hear that very much.
With this model and everything that you are doing, it's brilliant. It's something I want to implement this in Iceland. Thank you very much.
And do you think that sleep is included very well in training programs for healthcare professionals?
I don't think so. I think we need to include it much more. And I think we are in a similar situation by us with obesity, recognizing that as a disease and its importance. The sleep is similar, I think. It used to be something was just going to happen, and we didn't make so much attention to it. But now, when we know more and more about it, we realize how important it is. And I think that will be a part of healthcare education and training in the future much more.
Thanks, Arla. And just coming to Carl, I mean, I suppose similar in what you're thinking about training in the UK, and then also kind of particular to your talk, something that's always fascinated me is that we've had the knowledge around the science that you presented about, you know, biology of hunger and appetite and how this is being driven biologically as opposed to poor behaviors. Why are we not getting that traction in terms of training of healthcare professionals, let alone more widespread in society?
I've no idea about the training of healthcare professionals. However, what I will say about this knowledge of our neurobiology, things like our reward system, how satiety and hunger are integrated in the brain and things like the hypothalamus, what that has led to is we are starting to see more targeted drug development. So although, you know, a lot of drugs aren't getting approval yet, I think there are 3 currently EMA approved and there's 5 in America. But what you start to see is that clearly eating behavior is one of the many different routes into obesity, but even that has such kind of variety in that, and that's why we need to have more tools in our arsenal to target these different neurotransmitter systems and these different aspects of our neurobiology. So I talked before about a complex interplay between satiety, reward, and inhibitory control. We've kind of, we understand where these parts of the brain are. So we know satiety has hypothalamic involvement. Reward, we can see parts of the nucleus accumbens have hedonic hotspots in. And in terms of our inhibitory control, this is more prefrontal cortex. Now, what we're seeing is different drugs working on different neurons in these different areas. So, and we're starting to see combination therapy. So one drug that's available, I think I saw someone said it in Ireland, it's also available, so bupropion naltrexone. This acts on the POMC in the hypothalamus to kind of reduce satiety, but also because it has an effect on dopamine, this has effects in the prefrontal cortex, which might have an effect in inhibitory control. Other drugs like the GLP-1 drugs, liraglutide, Saxenda as well, which semaglutide, which is another formulation of a GLP-1 drug, which people are getting really excited about. These have work on neurons in the hypothalamus, but also in the nucleus accumbens. So these might target satiety and reward. So in terms of what I think you're saying that we know we understand some of these neurobiological processes and we have them for some time, but drug development takes a little while after that. And also because these neurotransmitter systems are involved in a lot of different things, they can also have some adverse side effects. So we often see drugs come and go as well. I think I'll stop there.
That's brilliant. I'm sure we could listen to lots more. Thanks so much. I might come to Susie next, if that's okay, Susie, because just again, going back to that theme of training, are you seeing any changes in your years as in advocacy, do you think there is some progression maybe in health professionals having a bit more knowledge?
There's definitely, and we see that in the groups with the way people are chatting about it too. And I think that's the thing, that there was always a worry for people in our community that they were afraid to talk about these things because, you know, it's also an Irish thing. We don't like to give out. We might give out to each other, but we don't like to go to the source of who's actually upsetting us. But what we're chatting about now is how you can actually raise this with people. Like, so one of our group members, she had a gynecological appointment and her weight was mentioned in a way that wasn't helpful. And she was really upset and she wasn't going to go back. But what we did was we sat out with her and we said, right, let's write a letter about this. A very pleasant letter just to your healthcare provider to say, this actually wasn't good. And she did, but she got a huge positive response back from him, that he didn't know what he didn't know what he said. He didn't know it was harmful. So I think that's sort of coming into it. Yeah, I think we've seen huge improvement, definitely.
Thanks, Susie. And maybe coming to you, Louise, just in the area of researchers, do you think, is there more of a role for the patient voice influencing research in this area?
Absolutely. I think like being involved with ASOI and also the EASO, the European Association for the Study of Obesity, it's really helped elevate the patient voice and kind of open a lot of researchers' eyes to, you know, I think especially maybe basic science and lab-based researchers who might not have kind of thought a lot about who is on the end of their research. I definitely have heard that firsthand from researchers. But also just like our landscape study and the Sláinte Care project have both had fantastic patient advocates on the committees for these, and like they're very active collaborators and they bring a fantastic insight to that. So I 100% think that that's going in the right direction and there's a lot of interest. I'm sure Susie will agree. I know ICPO get an awful lot of requests to participate in research, and I think as the years go on, it's getting more to be more active involvement rather than a tick box. I'm sure some people still do tick box exercises, but it's becoming, I think it's improving. I hope that Susie would agree with that.
I think it is, yeah, Louise. And I suppose as a new organisation, ICPO, we've kind of treaded very softly and we're trying to find our feet on how we can push back and when we can push back. But I have to say the advice we're getting from everybody here, because that's, you know, when we look back at this award that's behind me here that we won for World Obesity Day and the theme addressing obesity together, that is what we're doing. And the communication that we have between us at ASOI, between the HSE, it's fantastic in that we're learning from each other. We're learning a lot. We're being guided by you all because we're trying to find when we can push back. And we don't want to be tokens. We want to be heard for that. We want to help, you know, so yeah, I fully agree with you.
Great.
And hopefully the research is really massively or exponentially progressing in the area of medications. Carl mentioned that already of what's coming down the line. And and this has come up in a lot of questions. I might come to you, Donal, because access to medications is a real issue. And is this something, do you think, that the model of care will help to address, or that might change in the near future?
Yeah, I think so, definitely. And I think the model of care is a pathway to addressing the formal inclusion of medication in the treatment of people living with obesity. And I think the adapting of the Obesity Canada guidelines linked in with the National Clinical Pathway for Guidelines means they have to go to the healthcare, purse string holders for the budgetary implications, because what you cannot have with a disease like obesity is people who can afford it able to have access and those who can't not have access, because we know that the degree of obesity and the degree of complications associated with it is higher in the people who can't afford the treatment. So I think we will get there. I think we'll have to use the patient voice like we have seen. And for me, the patient voice in Ireland might have been a cliche and a tick box 4 or 5 years ago. Now it's, a partnership. So when Ray Darcy was putting me under pressure earlier in the week about the model of care, Maura came in from the ICPO and just took over. I gathered myself and came back a few minutes later, and I was able to deal with the rest of the interview. But that's the kind of partnership that you need, and we we have it. And I would say, Erla, just listen to you saying you'd love this in Iceland. I can tell you, you won't get it if you don't have patient groups like we now have, because we were trying this for, and Jean, you know this, for a long time. Some of the documents I showed, the policy documents I showed, go back to 2005 with similar recommendations, and nothing happened until really, I would say, we repeated the effort and had the patient voice on board. So it's good. And I was delighted to hear you say it's okay to wake up a few times, because you could begin to worry about that. And then once you start worrying, you're in a cycle of actually, I'm not sleeping well, and so I'm delighted about that.
That helped me a lot, at least.
Yeah,
and thank you very much for this tips. We have very powerful patient representatives here. We don't have any organization though yet, but very powerful people, and I'm going to tell them about this, and that is, it's the same. We have been having those document after document after document, and nothing happens,
Yeah.
So this is a very good tip.
Erla, one of your patients, Solveig, is one of my mentors who has taught me a lot. She's fantastic. And she spoke at our event in 2019 here in Dublin. So I think most of us here have met her. She's fantastic.
She's powerful.
It's interesting, isn't it? Because I think both ICPO and ASOI have learned so much and achieved much more by collaborating with our European colleagues. If we think of ECPO, which is the European version of ICPO, and EASO, which is European version of ASOI. And so we're all, I suppose, achieving more together, hopefully. The other thing I wanted to, because there's a huge amount of questions coming in on the area of diets, different types of diets. Does such a diet work? What do you think about this diet? I won't even list them all. I mean, you probably saw them there. There's ketogenic, intermittent fasting.
Jean, there was also one mention of, can I have a diet plan?
Exactly. Yeah. So I suppose we can completely understand this, because there is so many confusing messages coming from every direction at people, and it's very hard to see through that noise. So it'd be interesting to get people's thoughts. Maybe if I come to you first, Niamh, your thoughts on types of diets, or what?
Yeah, well, I suppose coming from when working with children and teenagers, the word diet is avoided. It's just about food. It's about meal plan. I think the word diet has changed over the years. And as a dietitian in training, you often learn about specific diets for, different diseases or conditions. So diets for perhaps for someone with irritable bowel disease, diets for Crohn's disease, diets for this, that. And really the meaning has changed now. I think there's been so much, in social media, in even celebrities maybe promoting this and that, and influencers, that really I think the meaning of the word diet has actually changed. And I would steer away, especially, as I said, when talking to children and teenagers, and just refer to the food that we eat and meal plan or nutritional plan. It's just more appropriate language, I feel. It doesn't bring in those connotations or perhaps some of those thoughts. But I mean, when it comes to, there's no one size fits all. It's very individual. So that are my thoughts on it.
Carl, you were nodding your head there, do you?
I just think it's completely agree with all of that, really. I think it's I think we all agree that there is no one size fits all, and just developing something that is sustainable and healthy for you is the best way forwards.
Yeah. I would agree with that. I mean, there's the amount of barriers that we have, and we're all so unique. And I said earlier, me as Susie, I'm completely different to anybody else, but there are things that we are learning so much. And Maura and I were chatting on the break here for this session, and we were saying about how it's a long day and we've been nervous about it, and we're all, sort of anticipating it. But after events like this, particularly that they're online and you don't have the debrief afterwards, we look for some sort of reward. And we're nearly looking for something nice. And listening to Carl is just mind-blowing for us, you know, because I went out and bought a cooked chicken today, and Maura has her boiled eggs ready, because we know these are our triggers. And what Diane said, learning your coping strategies, you know, and this is what's key. So we wouldn't consider we're on a diet. We're just trying to cope meal by meal, day by day. And that's our best way of trying to. But Carl, Carl and Erla, we're going to rob you both for our online meetings. We need you to be telling more of our patients all of this. It's fantastic.
Actually, Susie, sorry to put you on the spot again, but I was going to come back to you just to, you know, our case study, Emily, do you feel there was points within today that really would have been helpful?
Yeah, and it was fantastic to see everybody refer back to it, because it was so relevant. And I think, you know, we can all of us that were involved in the videos today in the role play can identify with some part of Emily's story. And I loved Erla's sort of her analogies earlier. I love analogies, I really do, because they really are like the foot on the pedal and going nowhere, you know. That, oh, I just was nodding going yes, yes, yes. I've felt that so many times. But for us, it's, people talk about this as a weight journey, a weight loss journey maybe, you know, and quite often thinking there's one treatment, one quick fix. So you're on a motorway and you're starting at A and you finish at B. But really now what we see is that there's speed ramps along the way, and it's not just one is like that, it's physical barriers, it's the hunger, it's the sleep, and they're the speed bumps. But then you can also get lost on that motorway and you go off onto a side little country road. And what would some of us do? We think we can work our way back by ourselves, when instead use the tools we need, use the sat nav, use a map, phone somebody, ask for help. Do you know? And that's one that stuck with us, is like, it's not straightforward. Obesity is a chronic relapsing disease, and we're all individual we need multi different treatments.
That summarized it so well, and I suppose ask for help is definitely a good take-home message. Donald, do you think there's going to be more help available?
Well, that's what the model of care is about, you know, introducing over the next number of years in a geographically accessible and geographically equitable way. I mean, that's the critical piece. You know, we've little pockets of activity at the moment that are inconsistent, and we need consistency. You know, when somebody goes to a diabetes center, they know what they're going to get. When they go for a cancer center, you know, they get the same treatment whether they're in Galway, Letterkenny, or Dublin, because there's pathways, there's evidence-based treatment, and that's where we're moving. So our duty is to ensure that the model of care is fully implemented. It is being implemented. So, you know, 44 dietitians have been recruited to deliver the adult weight management program in the community. Starting next year, there's piloting of the childhood or development of the childhood MDT within 2 areas with a view to national rollout. And then we have to have access to the bariatric services for the adolescents and adults. It's all there. COVID has given it more energy rather than taken energy away. But we're all waiting for the purse strings to tighten again, just because of such a big spend. So I think that's why we need, you know, you said it's stronger together. We're building momentum. Today's attendance and participation shows that. And everyone has gone away having learnt. There was one question in that I said I'd address, and it was about shift work. And
very quickly, because we're
but it was just the combination of Carl's talk and Erla's talk explain why shift work is a disaster. Your hedonic drives, your brain, your sleep pattern, chaos.
No, absolutely. And so I think the phrases I'm taking from the panel today are stronger together and ask for help, and healthcare professionals to ask for help too. We need to remember that too. Thanks so much to the panel. I think that concludes our panel session, and that that concludes the event. I just want to say a few thank yous. Thank you to all the speakers today, because you've really made this a fantastic educational event for all of us. Thank you to the RCPI Obesity Clinical Programme, in particular the Clinical Advisory Group, and to Donal O'Shea, who make this event a priority for us every year. Special thanks to Brendan O'Shea for all his work on the programme over the last 4 years, and best wishes as he finishes up as the Clinical Advisory Group Chair. This event couldn't have happened without the dedication of a core working group made up of the Obesity Clinical Programme team, and in particular the amazing Programme Coordinator Karen Gaynor. Also the committee members of ASOI, many of whom you've heard speaking today, and the ICPO advocates, particularly the extremely hardworking Susie Burney and Maura Murphy, but also all the advocates who have shared their experiences with us today. Lived experience is key in learning about obesity and designing our services for what is needed. So we're really fortunate to be able to work with ICPO. Thanks to Sarah O'Brien and the Healthy Eating Active Living Programme in the HSE Health and Wellbeing for their support. And a big thank you to Eamon and his team in HSE Communications and Press, because without him, we wouldn't have had such broad reach and engagement with members of the public, healthcare professionals, and the media. And speaking of reaching people, thanks so much to Helen O'Brien and Jean Lyons at Integrated Media Solutions for working round the clock and allowing us to deliver this virtual event. A final massive thank you to everyone who has attended today's event. We're all working together to change the narrative on overweight and obesity. And if everyone here speaks to their family and friends and colleagues, we can help to raise awareness and begin to see change happen. So I'm asking you to complete a quick survey at the end of the event to help us plan for next year. And we'd welcome any feedback and suggestions you have. And just a final reminder to follow us on Twitter and socials using the hashtag Overweight and Obesity. So with that, I'll conclude today's event, and hopefully we'll see you again next year.
There's a new link there, folks, for the meeting. The next meeting, there's a new link.